Welcome back, everybody. David here again with Med School Boot Camp. So in this chapter, we're going to talk about rheumatologic diseases. This is important contrast from our previous chapter in which we talked about primarily non-rheumatologic diseases. So as you can see, there's a variety of different pathologies that we're going to discuss here. We're going to talk about pathophys, conditions, presentation, diagnostics, and management. So if you all are ready, then off we go. So in this first video, we're going to talk about the ever so high yield rheumatoid arthritis. You probably know people who have rheumatoid arthritis. You've probably heard of it. And we always know that we can contrast this with osteoarthritis. Well, when we think about rheumatoid arthritis, it is a chronic inflammatory autoimmune condition that typically affects the joints, but as we'll see, there's also a lot of extra-articular manifestations as well. So if we jump into the pathophysiology here, we see that we have increased inflammation in the body that can lead to proliferative angiogenesis or the formation of new blood vessels. This process can also lead to increased granulation tissue and pannus formation, which is a type of thickened extra growth in the tissue or joint itself. This can ultimately lead to hypertrophy of the synovium with bone/cartilage destruction. So we don't have to get lost in the details here, but essentially we have an inflammatory response causes a dysregulation of tissue growth that leads to destruction of the joint itself. And one of the primary ways this happens is when IgM antibodies, the rheumatoid factor, binds against the Fc portion of IgG. And so if you draw your attention to this image over here, you will see rheumatoid factor antibody is an IgM antibody. And remember, IgM is a pentad, or that there's 5 separate antibodies that actually creates the IgM structure. And we said that these antibodies actually bind to the Fc portion, which is this portion of the antibodies right here of IgG molecules. So that is to say that the RF antibodies, or the IgM RF antibodies, bind to the Fc portion of IgG antibodies. And this is one of the primary pathophysiologic mechanisms of rheumatoid arthritis. And so this is an important part of the process that actually triggers inflammation and the formation of all these things we talked about in the body. Now, there are some certain risk factors which patients who develop rheumatoid arthritis are more likely to have. And this starts with genetic predisposition, including the HLA-DR1 and HLA-DR4 genes, in addition to smoking. And so the presentation of rheumatoid arthritis can be this whole thing of nature versus nurture. Patients can be predisposed to rheumatoid arthritis from having these genetic conditions. They can compound this with smoking or the nature environment, and this can actually lead them to have rheumatoid arthritis. So there's a variety of different ways patients can get it, but it's a combination of genetics and the environmental factors that actually leads to rheumatoid arthritis in patients. Now, if we look at the associated conditions here, 2 key ones I want you to know include Felty syndrome, which is a triad of arthritis, neutropenia, and splenomegaly, and K.A.N. syndrome, which is pneumoconiosis. And so really the way they would ask about this on a test question is to give you a patient who has obvious rheumatoid arthritis, but then they also mention, oh, they're neutropenic and they might have splenomegaly, and then their diagnosis is changed to what's called Felty syndrome. But this is a condition of which rheumatoid arthritis can be associated with. Additionally, K.A.N. syndrome can occur in patients who have both rheumatoid arthritis and occupational exposures from things like silica, asbestosis, borreliosis, etc. So keep these in mind as similar but separate conditions they might ask you about on test day. Now, when we look at the presentation here, we see that rheumatoid arthritis is more common in women, increased risk with age, and can present with a variety of constitutional symptoms such as fever, fatigue, myalgias, and weight loss. We'll see this a lot in this chapter. It'll be a recurring theme that autoimmune conditions are often inflammatory in the body, and this can lead to both systemic symptoms, as we're seeing here, fevers, myalgias, night sweats, just generalized symptoms, as well as some more specific symptoms as well. So what are some of those specific symptoms? Well, we can have symmetric involvement of some of the joints, particularly the MCP or PIP joints, as well as the wrist, knees, and some morning stiffness that lasts greater than 30 minutes. Super, super important here. This is contrasting with osteoarthritis. Remember, osteoarthritis is typically asymmetrical. It typically involves one joint or the other. It also typically has morning stiffness that lasts less than 30 minutes. Usually patients wake up in the morning, they're stiff, but then they get the joints kind of moving. Contrast this with rheumatoid arthritis, in which the morning stiffness is more prolonged. It lasts for a longer period of time in these patients. Additionally, we want to look at the joints here. So if you draw your attention to this image right here, you can see some of the classic areas rheumatoid arthritis is going to affect, including the wrist, the MCPs, or the metacarpal phalangeal joints, and the PIP, or the proximal interphalangeal joint. Notice there is sparing of the distal interphalangeal joint, right? This is not typically affected in rheumatoid arthritis. Why is this important? Because it is affected in osteoarthritis. In OA, these are going to be inflamed as well, in addition to some other conditions such as psoriatic arthritis. So this is a key joint. The distal interphalangeal joint, or DIP, is a key joint differentiating rheumatoid versus osteo versus psoriatic arthritis and some other conditions as well. So keep this in mind. We can also see patients who have this kind of ulnar deviation in the wrist joint. Again, this is a very classic finding of rheumatoid arthritis, and you can also see in this image some of the swelling of the joints, but notice that these ones are fairly spared. Why? Because the distal interphalangeal joints are typically more affected in osteo or psoriatic arthritis. And so again, just to drive that point home, the DIP or CMC is typically spared in rheumatoid arthritis, and we're contrasting this with osteoarthritis. Now, patients can also have some other key joint deformities. These include things like atlantoaxial subluxation, which is the cervical vertebra that can actually move and cause paralysis type symptoms in a patient. This also includes joint deformities such as the boutonniere, sometimes called boutonniere deformity, which is PIP or proximal interphalangeal joint flexion with DIP hyperextension. In addition, we contrast that with this swan neck deformity, which is opposite PIP hyperextension with DIP flexion. Again, draw your attention to these images right here. We can see the boutonniere or boutonniere deformity over here and the swan neck deformity over here. And I want you to appreciate the key differences here. With the swan neck deformity, you can see flexion of the DIP with the hyperextension of the PIP. Again, this is the distal joint versus the proximal joint. Now, if we look at the condition over here, we essentially see something opposite. We see flexion of the PIP and hyperextension of the DIP. So again, these are some classic hand findings that we can see in a patient who has rheumatoid arthritis, and they are so classic that they have specific names. Now, it's also important to know, as we said at the beginning of this video, there are some extra articular manifestations, including rheumatoid nodules, interstitial lung disease, pleural effusions, carpal tunnel syndrome, or anemia of chronic disease. Again, these are associations that patients can have, but the main one I want you to note here is that of the rheumatoid nodules, because these are non-tender, firm subcutaneous swellings that you can actually see or feel on physical exams in a patient. Additionally, if we consider the histopathology, we can see over here a rheumatoid nodule actually being formed. And so here's the image just in a bigger screen, right? You can appreciate here this kind of area of central fibrinoid necrosis, meaning that there's death to the tissue or necrosis of the area in the middle with a bunch of cells that's actually surrounding the necrotic structure itself. So again, all of these little purple dots are cells, and this area in the middle you can see is fairly acellular. That's where the necrotic area is. And this is the pathology or the histopathology of the rheumatoid nodule themselves. Now, when we think about diagnostics here, some really key things to note, but in general, this is a clinical diagnosis. If we were to look at an x-ray, we would see soft tissue swelling, osteopenia or bone softening, as well as marginal erosions of the bone and cartilage and joint space narrowing. And so if we draw our attention over here to this image, you can see the generalized osteopenia or bone softening, as well as the joint space narrowing and erosions of this articular cartilage right here. For me, one thing that I really use to compare and contrast osteoarthritis and rheumatoid arthritis, although maybe it's not always 100% accurate, is whether or not I see shifting of the joints. So in osteoarthritis, we expect to see joint space narrowing, right? I expect to see compression. But here you can appreciate that these are kind of offset, particularly this one. See how it's kind of shifted over? I associate that more with rheumatoid arthritis, particularly for board style questions. Now, when we think about our serology here, really important autoantibodies to keep in mind include anti-cyclic citrullonated peptide or anti-CCP. I put this as a high yield point here. And the reason is because this has approximately a 90% specificity for rheumatoid arthritis. That is to say, if a patient does not have this antibody, it's pretty unlikely that they have rheumatoid arthritis. Remember, specificity, we're dealing with the proportion of people who have a condition and test negative. And a test with high specificity is used for confirmatory purposes. So a test with a high specificity has few false positives. And thus a patient who has this antibody, knowing that this is a high specificity test, it's unlikely to be a false positive. If they have this antibody, it's likely that they do have rheumatoid arthritis. Now, some other non-specific tests that we can consider include things like rheumatoid factor and anti-nuclear antibodies. Classic trick though, rheumatoid factor, we expect that everyone has rheumatoid arthritis with rheumatoid factor, but this is not the case. This test actually has less specificity than the anti-CCP test. That is to say, patients can have a negative rheumatoid factor and still have rheumatoid arthritis. Rheumatoid factor itself is not enough to diagnose somebody with rheumatoid arthritis. And just because somebody doesn't have rheumatoid factor or even the anti-CCP antibody doesn't necessarily rule out rheumatoid arthritis. There are patients that can have neither of these autoantibodies and still have the condition. But for the most part, if you have these antibodies, you're more likely to have the rheumatoid arthritis. Now, to wrap this up, we can consider arthrocentesis as well, which is going to show mild inflammatory synovial joint fluid with white blood cells in the range of 5,000 to 50,000. Compare this with osteoarthritis, which is non-inflammatory. The white blood cells would be less, versus septic arthritis, in which the white blood cells would be greater than 50,000 because there's just tons of neutrophils and other white blood cells trying to fight the infection. Now, if we consider the management for this condition, we're going to talk about symptom management, including anti-inflammatories such as NSAIDs, selective COX-2 inhibitors such as celecoxib, and glucocorticoids. Again, we said this is an inflammatory process, so giving a medication that decreases the inflammation is going to be useful. It should make sense to us. Now, when we think about long-term treatment options, we're going to be thinking about disease-modifying antirheumatic drugs, also called DMARDs. These include things like methotrexate, which is the first-line medication for these patients, but we can also consider other medications such as hydroxychloroquine, sulfasalazine, and leflunomide. And if these don't work for the patient, if the DMARDs don't work, we have some other options as well, including biologics for persistent disease such as TNF-alpha inhibitors, which can be used as well. So a key point here is you want to start with the least invasive thing, the safest medication. So these include prioritizing things like anti-inflammatories over glucocorticoids. We know glucocorticoids have a lot of adverse effects. We want to start patients on DMARDs, particularly methotrexate, early because there's been a lot of good research showing that this can be helpful in delaying or even preventing some of the severe rheumatoid arthritis findings down the road. Now, everything we do is pros versus cons. Methotrexate is the first line, but there are also some adverse effects that the patient can present with. These include things like pulmonary fibrosis, hepatotoxicity, and even bone marrow suppression. So keep this in mind. And a test question, if a patient is started on these medications, what kind of things they might show up with later if they were to have a complication. Now, when we think about a classic vignette here, it might be something along the lines of a 38-year-old woman presents to the clinic with a chief complaint of bilateral hand pain and stiffness. The patient reports some increasing fatigue over the last several months, but no obvious fluctuations in her weight. Vital signs are within normal limits, but on physical exam, you notice the patient has 4 out of 5 strength on the hand grip test, which the patient attributes due to the ongoing pain, not allowing her to squeeze any harder. You also notice hyperextension of the proximal interphalangeal joint or PIP joint and flexion of the DIP joints. The lab studies show an elevated CRP inflammatory marker, but a negative rheumatoid factor. The question then asks you what's the most likely diagnosis. It can give you osteoarthritis, rheumatoid arthritis, polymyositis, fibromyalgia, or a lot of similar conditions, right? The key here is that this patient still most likely has rheumatoid arthritis. The tricky part of that question stem is that they said there was a negative rheumatoid factor. But again, I highlighted this for this reason. Just because somebody has a negative rheumatoid factor does not exclude them having rheumatoid arthritis. A very classic confusing points for students. Just because somebody doesn't have the antibodies doesn't completely rule out rheumatoid arthritis. We have to use the whole clinical picture. And this patient has very classic signs and symptoms as well as physical exam findings that would be indicative of rheumatoid arthritis, regardless of their rheumatoid factor antibody level. So just a quick summary for this video, a lot to digest here. Rheumatoid arthritis is an autoimmune inflammatory condition that affects the joints and other areas in the body as well. It's likely to present with a variety of systemic as well as joint symptoms, in addition to some extra-articular manifestations such as rheumatoid nodules, which we talked about here. Typically, this is a clinical diagnosis, but there's a variety of different things that we can see on imaging as well as in serology to work up these patients. We can also consider arthrocentesis as well, which again is going to be mildly inflammatory. When we think about management here, it's really about controlling the patient's symptoms and decreasing the likelihood of disease progression. So this includes a variety of things such as anti-inflammatories as well as disease-modifying antirheumatic drugs, particularly methotrexate as the first line. If this doesn't work, we have some backup options as well. And so these are some of the really key points that they like to ask you about on test day. And so I know this video has a lot of information to go through, but it's really, really high yield to be able to compare and contrast this with other rheumatologic diseases as well as with osteoarthritis. This is stuff they really like to ask you about on test day. Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we're going to talk about systemic lupus erythematosus. Sometimes this is abbreviated as SLE. This is a super important high-yield pathology that they love to test you on because it can present in so many different ways. So SLE is a multi-system autoimmune disorder. It can affect the heart, the lungs, the kidneys, some common skin manifestations we'll talk about. And although the exact cause is unknown, we believe it's dealing with autoimmune overreactivity as well as a combination of environmental factors and possibly even hormonal factors as well. So if we draw our attention to the pathophysiology here, SLE is a type 2 and type 3 hypersensitivity reaction. So just as a quick reminder, our type 2 hypersensitivity reaction is dealing with antibodies that can then bind to a cell, leading to cellular destruction. It can also lead to increased inflammation. So that is to say that the antibody can then bind to the cell. This can activate the complement system, which can again cause inflammation and ultimately destruction of the cell. Now, when we're talking about a type 3 hypersensitivity reaction, we're talking about an immune complex. That is to say, we're not just talking about the antibody itself, but now we're also talking about an antigen that's bound to the antibody. So you have this antigen-antibody complex, which is the compound that then ultimately activates the complement system as well, again leading to inflammation and cellular destruction. So again, this is a common thing that we see in SLE, or systemic lupus erythematosus. A good way to remember the type 3 hypersensitivity reaction is to remember we have 3 key players here. We have the antigen, we have the antibody, and then the whole thing is going to be activating the complement system. So those 3 things together, antigen, antibody, complement, for the type 3 hypersensitivity reaction. What's this going to do? Well, either way, it's going to lead to antibody development, an autoimmune reaction, which ultimately, as we said, increases complement activation and inflammation in the body. This then leads to multi-system tissue damage. This is a big cascade of events that occurs for a patient. But the main thing to know is that these reactions can occur in so many different places in the body. It's not a localized reaction. Now, there are a few key risk factors for the development of SLE. one of which is genetics. So the HLA-DR2 and HLA-DR3 gene have been shown to be associated with people having a higher risk of developing lupus. Also, patients with decreased classical complement proteins are at a higher risk. That is to say that some individuals who have had a decrease in the proteins in the complement system, specifically the C1q, C2, and C4 components, have been shown to be at a slightly increased risk of developing lupus as well. We also have some other key associations such as increased estrogen. Based on the types of patients who get this in the age range, we suspect there might be a link between elevated estrogen levels and developing this condition. Additionally, some environmental factors such as smoking, UV light, and some medications, particularly hydralazine and procainamide, have been shown to increase a patient's risk of developing lupus. We'll talk about some medications later in something called drug-induced lupus, which has a very unique finding that they love to ask you about on test day. Now, when we drop down to our presentation here, we said that this is more likely to occur in women, and the age range is approximately about 15 to 45. And this makes sense to us. Why? Because we said that increased estrogen has been shown to be an associated risk factor for developing this condition, and these are patients where you might expect to see higher estrogen levels compared to somebody who's, say, 65 postmenopausal, or in a younger patient, say they're 7. Now, some classic findings we're going to see in these patients include constitutional symptoms. Again, this is a multi-system body-wide disorder. You can see things like fevers, fatigue, myalgias, and weight loss, which more or less are non-specific, but it indicates there's a system-wide problem going on for these patients. Now, really key here, we're going to talk about some cutaneous involvement, some musculoskeletal things, and some additional manifestations as well. When we talk about the cutaneous involvement, high yield point here, the malar butterfly rash is super important. So if you draw your attention to this image over here, we can see this rash that's supposed to look kind of like a butterfly shape, right? You can see the redness here goes across the nose, and in theory, this kind of looks like a butterfly wing that is open, and this is a classic finding. Notice another key point is that we say this type of rash spares the nasolabial folds. So you can see that there's kind of a white area here where there's not really the rash present, and then you can see more of the rash in the pink areas here along the cheeks. This is an important contrast with another type of facial rash called rosacea, which we talk about more in our dermatology section. Another key rash they like you to know is that of a discoid rash. So if you draw your attention to this image over here, you can see we have very well-defined erythematous plaques that are forming in kind of a discoid shape. This can ultimately lead to scarring and atrophy of the skin as well. So it's important not to forget about this type of rash. I think a lot of students are able to remember the butterfly rash, but test questions like to ask you about the thing they don't think students are going to know. If they expect everyone to remember the butterfly rash and SLE, well then they might show you a picture of a discoid rash on a patient, and they really be able to trick students in that way. So don't let it trick you. Know that there's two key types of rashes that we need to know for lupus. One is the butterfly rash, and the other is the discoid rash. And finally, these patients can also have a generalized maculopapular rash because of photosensitivity. So oftentimes it'll talk about a patient in the question stem who's been out in the sun, and all of a sudden they have a rash on their face. It's in a unique distribution, potentially a butterfly distribution, and they're also having some other associated signs and symptoms. This patient might need further workup for lupus. Now, when we think about the musculoskeletal things, we're going to have symmetrical polyarthritis, inflammation, particularly of the MCP and PIP joints, without joint deformity because it's contrast with RA. In a previous video, we talked about rheumatoid arthritis, and we talked about how some of the bones can get compressed and deformed and kind of be a bit outside of the area that we would expect them to be. But here, we have similar areas affected, similar joints, but we wouldn't necessarily see that joint deformity. It's important to keep in mind here, like I said, this is an autoimmune systemic condition. So we have cutaneous problems. We also have MSK problems. And we have a lot of additional things, one of which is lupus nephritis. And this is particularly important because this is a common cause of death in patients who have lupus. They can get this lupus nephropathy. It becomes to the point where it's untreatable, and they can pass away from this as well. So again, now we've talked about skin findings, musculoskeletal. Now we're talking about the renal system. What else can we see in these patients? We can see cardiac findings. We can see pericarditis. We can see lung findings such as pleuritis. You can see painless oral ulcers as well. This is very commonly used in questions because it's kind of a distractor in a way. Why would somebody with lupus have ulcers? We don't typically think about that, right? We typically think about the rash, but the painless oral ulcers can be new to a patient, right? That can be the presenting sign and symptom that they have, as well as some other constitutional symptoms, and this could be pointing to a patient who has lupus erythematosus. We also can see things like cytopenias, lupus cerebritis, which is cognitive dysfunction. This can lead to strokes and even seizures as well. And finally, an increased risk of thrombosis. So again, we can affect the hematologic system, we can affect the brain, we can affect the mouth, the heart, the lungs, the kidneys, the MSK, the whole body can be affected in lupus. And so they often will present you with a patient with tons and tons of findings. They might be pointing you in the direction of an SLE presentation. Now, one other important key cardiac finding I want to talk about here is Libman-Sachs endocarditis. And the reason I gave it its own line is because I really want to highlight it here. It's a particular type of endocarditis that they love to ask you about on these exams. And one of the memory aids that we use is to remember that L
SE can be seen in SLE, or systemic lupus erythematosus. Again, just a little memory aid there, but Libben-Sachs endocarditis is basically a type of endocarditis that is what's called a non-bacterial thrombotic endocarditis, because a lot of endocarditis we talk about is dealing with the bacteria, right? It's a Staph aureus infection, it's a strep viridans infection, but here it's a non-bacterial endocarditis. This is also sometimes called merantic endocarditis. And although this is rare, vegetations can actually form on the mitral and aortic valve, just like you would expect to see in a bacterial endocarditis. So again, a special unique presentation of endocarditis here in lupus. Now, when we move on to our fatal complications, we already talked about kind of lupus nephropathy being a common one, so renal disease. Patients can get infections. Why can they get infections? We'll think about some of their other symptoms. They can be cytopenic as well, so we can't fight off these infections as we would in a normal healthy individual. Additionally, we can also see things like cardiovascular disease, and the memory aid for this is that patients with SLE die with redness in cheeks. R stands for renal disease, I stands for infections, and C stands for cardiovascular disease. So again, these patients are at increased risk of these conditions, and these are also three of the conditions that are most likely to cause them to pass away. Now, I want to touch on a special patient population that can have special complications from lupus, and that is patients who are pregnant. So in pregnancy, patients can have an increased risk of flares from the condition. They're also at an increased risk for something called neonatal lupus if they have the anti-Ro/SSA or anti-Law/SSB antibodies. And in a different video, we're going to talk about Sjogren's syndrome. And these are antibodies that we classically see in the Sjogren's syndrome condition. And the problem is that patients that have these antibodies can actually have something called neonatal lupus passed on to their offspring. And so as we'll see in the Sjogren's syndrome video, there are a lot of associations with these different autoimmune conditions. So a patient who has lupus might be more likely to have Sjogren's syndrome, thus they might be more likely to have these antibodies. If they have these antibodies, it increases the risk of a condition called neonatal lupus because these antibodies can pass through the placenta. So again, the association here is that patients who have lupus are at a higher likelihood of having Sjogren's syndrome as well. They're at a higher likelihood of having these additional antibodies, and thus a higher likelihood of passing them on to the fetus, causing neonatal lupus. This is very concerning because this can lead to congenital AV heart block, which as you can imagine can be problematic for a newborn baby. This can also lead to a periorbital or diffuse rash, as well as cytopenias and transaminitis. So again, a patient who has these antibodies that can pass through the placenta puts the baby at risk for further complications. Why? Because they can develop neonatal lupus. Now, if we draw our attention to our diagnostics here, you'll see that this is often a clinical diagnosis. However, there are a couple key antibodies that we can use for diagnosing this condition. And the main ones they want you to know are ones called anti-double-stranded DNA antibodies and anti-Smith antibodies. There are some other antibodies they might ask you about that are more non-specific. These include things like anti-nuclear antibodies, which we've seen in a lot of different conditions, these ANA antibodies. And we can also see decreased levels of complement proteins such as C3 and C4, as well as increased ESR and CRP. Why do these make sense? Well, decreased complement proteins can be seen in somebody who has a flare. Why? Because we have activation of the complement system. Increased activation of the complement system is going to then use those proteins. So the fact that we have this in the pathology leads us to actually see the decreased complement proteins on serology. And again, this is an inflammatory condition, so our inflammatory markers, ESR and CRP, can be elevated as well. So again, a lot of things to know here, but the one that I highlighted, the one I really want you to know that's high yield for test day, is knowing these two antibodies and their association with systemic lupus erythematosus. Again, they're not going to try to trick you with all these nitty-gritty details. They just want you to know the basics, the big stuff, right? So if they give you labs and they talk about this antibody, well, that's likely leading you to a diagnosis of SLE for the patient. Now, a couple key points here. ANA is sensitive but not specific, and that is to say that a negative ANA or antinuclear antibody means there's a low likelihood of lupus being the actual disease. So again, just review from our biostatistics, something that has high sensitivity is good for ruling out a disease. So a high sensitive test in ANA, if that's then negative, it's going to help us rule out the disease. It's low likelihood of SLE being present. Specificity is for ruling in a disease. And so if we say that it's not a specific test, that means just because somebody has a positive ANA doesn't necessarily mean they have lupus. It's not specific. It's not good for ruling in the disease. A lot more detail on sensitivity and specificity on our biostatistics section, so go ahead and check that out if you're unfamiliar with that content. Now, one key point I want to mention here as well before we move on is that there's increased risk for false positive RPR and VDRL. And why is this important? Because these are things that we test for syphilis. And this is important because we don't want to confuse a diagnosis of lupus with a diagnosis of syphilis, right? Obviously, the treatments are not the same. But the point here is that the RPR and VDRL antibodies react with something called cardiolipin, which can be seen in a patient who has syphilis. There's a variety of other conditions which can also lead to a false positive reaction. These include things like viral infections, such as hepatitis, patients who are pregnant, patients patients who are taking certain drugs like procainamide, or patients who have rheumatic fever as well. So again, although this is a test that we use for syphilis, it's not super specific and it can cause a false positive in a lot of other conditions as well. So be mindful of that, right? If you see a positive test, but you still think the patient likely has lupus because of all of these other findings up here, the patient probably does have lupus, unless they're pointing you in the direction of syphilis, which is going to be quite a different presentation for these patients. Now, when we move on to our management options here, one of the mainstays is going to be things like hydroxychloroquine with glucocorticoids, other immunosuppressants, and NSAIDs for symptom management. Now, important to know here that hydroxychloroquine is a really useful antimalarial drug that can really help these patients in their symptoms. However, it does not come without cons. Hydroxychloroquine can actually be very toxic to the eyes, and that's why it's really important that these patients have routine eye exams when taking this medication. It's also important to avoid things that would trigger the symptoms or make things worse. These include things like UV light and smoking, right? We previously talked about how these are risk factors. They increase the likelihood of this condition occurring. So again, you want to avoid those things that can trigger a flare and make things worse. Now, the final thing we're going to touch on in this video before wrapping up is a special condition called drug-induced lupus. These patients present with a similar presentation of lupus, right? They might have the rash, they might have some of the systemic findings, but it's due to a medication, it's due to a drug that they're taking. And some of the classic ones that they like you to know include methyl-dopa, hydralazine, isoniazid, procainamide, and sulfa medications. This is not an all-exhaustive list. There are some other ones, but those are the ones that are most commonly tested. So again, if a patient presents with what you think is lupus, the question could be tricky, and they could tell you about the patient's medication. It could ask you, what's the best next step, or what should we try for the patient? Well, if they're taking one of these medications that can be causing drug-induced lupus, that's a good idea to maybe stop taking that medication or transition to a different option. Alternatively, you can also get a very important test, and it's really high yield to know that these patients have a positive antihistone antibody. So again, we talked about some of the really important antibodies up here. I even put the high yield marker for the anti-double-stranded and the anti-Smith, but for drug-induced lupus, we can get the antihistone. So if you can't determine is it drug-induced lupus or regular lupus, that's a reasonable option as well. Well, let's check the antibodies. Which ones are positive? Is it these antibodies or is it this antibody? So again, these are a variety of different ways that they can ask you questions about lupus on test day. So just a real simple way they can talk about this. Again, there's so many different ways they could approach this question, but they could say something along the lines of a 33-year-old woman presents to the clinic with a chief complaint of fevers, fatigue, and weight loss over the last 3 weeks. The patient reports experiencing multiple sunburns on her face despite minimal sun exposure. On physical exam, you notice a mildly erythematous rash on the face that spares the nasolabial folds. The question can then ask you, what's the best antibody to look for? They're going to give you a variety of different things here. They're going to give you the ANA. They're going to try to throw you off. They might give you the anti-Ro or anti-Law antibodies, which are more associated with Sjogren's syndrome. And then eventually they're going to give you one of the correct answers, which is going to be the anti-double-stranded DNA antibody or the anti-Smith antibody. So just a quick summary to wrap up this video. Tons of content here. Feel free to watch again if needed. But systemic lupus erythematosus consists of a type 2 and type 3 hypersensitivity reaction. It's a systemic, widespread bodily reaction, an autoimmune reaction in the body that activates complement system, leading to increased inflammation and ultimately tissue damage and destruction. Presentation is typically going to be a woman in the middle age with a variety of different findings here. Again, skin findings, musculoskeletal findings, kidneys, lungs, everything can be affected, including the oral ulcers that they can often ask about as well. Remember, this particular type of endocarditis, again, it's a non-bacterial endocarditis, which makes it unique from some of the other ones that we need to know on test day. Always keep in mind these special associations with patients who are pregnant and the increased risk of neonatal lupus if patients present with these antibodies. Diagnostics, this is typically a clinical diagnosis, but again, we talked about some very specific antibodies and some less specific antibodies as well. Don't forget that some patients can actually present with a false positive RPR-VDRL, and sometimes this is how they would like to trick you on test day. When we talk about the management here, we're talking about immunosuppressants, we're talking about hydroxychloroquine and NSAIDs for symptom management. Hydroxychloroquine is a good medication for this. However, it does come with some risk for the eyes, and thus regular eye exams is important. And finally, we also need to know about the special scenario of drug-induced lupus. Again, similar presentation to above. However, these patients have the lupus presentation not because they have a true autoimmune reaction, but because they have a medication that is causing a similar presentation in their body.
Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we're going to talk about another autoimmune condition, and this one is called Sjogren's syndrome. So Sjogren's syndrome is similar to other autoimmune conditions and can even have some overlying physical exam findings that we would see in other things like lupus, rheumatoid arthritis we talked about previously. But a unique thing about Sjogren's syndrome is that it really targets moisture producing things, such as our lacrimal glands and our salivary glands. So let's jump right into the pathophysiology.
When we consider this condition, we're thinking about an overactive immune system or an atypical response. The increased activity can lead to lymphocytic infiltration and destruction of the lacrimal and salivary glands. Like I said, there's a lot of overlap with some other conditions, but we're really focusing on moisture-producing glands in the body. It's important to note that there are a lot of other associated conditions, and we've talked about these in some of the other videos, but these include things like RA, SLE, Raynaud phenomenon, viral infections, in addition to primary biliary cirrhosis, also called PBC. This is important to keep in mind because a question that they like to ask on board exams is to give you a patient presentation and ask about which associated conditions might be found in the patient as well. So again, if a patient has primary biliary cirrhosis, something we think about as more of a gastrointestinal problem, there is an association between this condition and Sjogren's syndrome. Some of the easier ones to keep in mind are other autoimmune conditions, rheumatoid arthritis, lupus. It's known that patients who have one autoimmune condition are more likely to have other autoimmune conditions as well. And so always keep this in mind on test day. Now, when we think about our presentation here, this condition is more common in women, like a lot of other autoimmune conditions as well, and we're thinking about approximately the 40-ish age range here. That's not a hard rule. The question can ask you about a 27-year-old patient. They could ask you about a 57-year-old patient. But in general, we're kind of thinking about this age range with this particular condition. Now, this pathology is really going to focus on the glandular symptoms. And so patients are going to present with findings such as keratoconjunctivitis sicca, which is the fancy way of saying dry eyes. And this is when patients will describe having a feeling of dirt or sand in their eyes. So if a patient comes to the clinic, right, and they're saying my eyes have felt really dusty lately, I've been rubbing them a lot, they've felt dry, this could be dealing with this presentation. This could be dealing with this symptom, which can be seen in Sjogren's syndrome. Now, another classic finding these patients can have is something called xerostomia, which is just a fancy way of saying dry mouth. Important to note that these patients can have difficulty with chewing or swallowing, right? If they don't have the saliva, it's harder for them to swallow foods, particularly dry things. Think about crackers. How difficult would it be to swallow a cracker if we didn't have moisture, if we didn't have the saliva in our mouth to help that transition down the esophagus? These patients can also present with an increased risk of cavities or dental caries and something called halitosis, again, fancy word for bad breath. So hopefully you start to develop a little theme here, right? These patients are really dry. Why are they really dry? Because we have destruction of their glands. And if we have destruction of the glands that produce saliva or other liquid substances in the body, it would make sense that these patients would have a dry presentation. Moving on, we can talk about things like xerosis or dry skin in addition to joint pain for these patients. Now, a key point I want to highlight here so that you don't get confused on test day or in the clinic with a patient is that you don't want to confuse this with age-related sicca syndromes. So as we get older, typically we get a little bit more dry. The mouth can get a little bit more dry. We can have less saliva. So you could see some of these findings. We talked about the dry eyes, the dry mouth, and the dry skin. And while these symptoms can be present in Sjogren's syndrome, they can also be present in something called age-related sicca syndrome. And so you might be asking yourself, how am I going to differentiate these on test day? Well, here are some key ways that you can do that. One of which is going to be the age of onset. So typically, age-related symptoms are going to present a lot older. These might present to more than 70, 80-year-olds versus we talked about this condition, we're thinking about maybe 30, 40, or 50-year-olds, a little bit of a younger presentation. But this may not be readily obvious. The best way to actually do this is to consider some of our lab options. And these patients would have a normal antibody test. We're going to talk about pretty soon that patients with Sjogren's actually have some different unique antibodies that can confirm the diagnosis, and we would not expect to see these antibodies in age-related sicca syndrome. And finally, we can also differentiate these by looking at the biopsy. So patients with age-related problems are going to have a normal biopsy versus patients who have Sjogren's syndrome, we said, are going to have lymphocytic infiltration, which you can see in this image right here. We'll talk more about that in just a moment. When we think about our diagnostics here, it's important to keep in mind that this is often a clinical diagnosis. However, there are a couple unique antibodies that we need to know. These include the anti-Rho/SSA and the anti-Law/SSB antibodies. If they give you these in a question at this level, it's basically telling you that the patient likely has Sjogren's syndrome. Keep in mind, however, there are some other things we can see in labs as well that are not quite as specific for this condition. So patients with Sjogren's syndrome can have a positive rheumatoid factor. Again, don't just associate rheumatoid factor with rheumatoid arthritis. We talked about in a previous video that patients who have rheumatoid arthritis can actually have a negative rheumatoid factor. And a lot of students get confused by this. They think that rheumatoid factor is like for sure 100% patient has rheumatoid arthritis. That's not necessarily the case. Patients can have rheumatoid arthritis without rheumatoid factor, or they can have rheumatoid factor without rheumatoid arthritis. Similar thing here. Patients can have rheumatoid factor and actually have Sjogren's syndrome, a separate autoimmune condition that is distinct from rheumatoid arthritis. Now, patients can also have the ANA, anti-nuclear antibody, as well as an elevated ESR and CRP, indicating an inflammatory reaction in the body. Now, a really important histopathologic image they'd like you to know on test day is the one shown here, which is a salivary gland biopsy showing dense lymphocytic infiltration. So if you draw your attention to this image over here, you can see all of these deep, dark purple cells, right? These are all lymphocytes. This is infiltration, lymphocytes going into the glands, destroying the glands. And this is what we talked about up here. Lymphocytic infiltration, destroying the glands, leading to the presentation, leading to the symptoms. So if we understand the pathophysiology, we can understand the presentation. We can understand the diagnostics. And that's what we want to get at here. We don't want to be forced to memorize these things. We want to understand what's going on because that's how we apply the information on test day. And finally, one of the last diagnostics they like you to know for this condition is something called a Schirmer test. And this is looking at decreased production of tears measured by a filter paper near the lower eyelid. And so the idea is that this is a test to measure our tear production. And so if we have the eyeball and we put a piece of paper near the lower eyelid, we can actually measure how much tear production is made over time by triggering tear production and measuring how far down the paper it gets over time. It's an indicator of how much the eyes are able to create tears, or a way to quantify the tear production over a given amount of time. And so if we compared a normal test with a patient who had Sjogren's syndrome, we would suspect that the patient with Sjogren's syndrome would have less tear production, or they'd have less wetting of the paper strip. Why? Because they have dry eyes. Why do they have dry eyes? Because we've destroyed the glands that are allowing for tears to be produced in this particular condition. Now, when we think about our management here, it really comes down to symptom management. These are going to include things like artificial tears or saliva, muscarinic agonists, hydration, and oral hygiene. Muscarinic agonists are useful. Why? Because they stimulate the parasympathetic nervous system, which can increase the production of saliva. Additionally, oral hygiene is important. Why? Because we said that these patients are at increased risk of cavities and dental caries because they're not producing saliva. This is a protective mechanism in the mouth. If we're producing less of it, we have an increased risk of cavities. So that leads the patient to need to be extra aware of their oral hygiene going forward. Now, in severe cases, patients can be put on immunosuppressants or glucocorticoids. Now, to wrap up this video, there's a couple key complications they'd like you to know for this condition. And the main ones are that patients have an increased risk of B-cell lymphoma, corneal damage, and neonatal lupus as well. Specifically, patients have an increased risk of malt lymphoma. And so again, sometimes they'll ask you about that in a question. A patient will have Sjogren's syndrome, and they'll say, what is the patient most likely at risk for? Well, one of those conditions could be an increased risk of malt lymphoma. The corneal damage should make sense to us. Why? Because these patients aren't producing enough fluid in their eye, predisposing them to being dry and being damaged overall. And finally, there's an increased risk for neonatal lupus. Neonatal lupus is a problem for a baby because it predisposes them to have an increased risk of heart block, various rashes, or cytopenias. And so in a patient who has Sjogren's syndrome, there's an ability for these antibodies to be passed along to the baby through the placenta, and thus leading it to a higher risk of developing neonatal lupus. So a classic vignette they might ask you about on test day could be something along the lines of: a 42-year-old patient presents to the office with a chief complaint of dry eyes and a new lump on her neck. The patient reports noticing the lump about 1 week ago, but she has also had severely dry and burning eyes for several months. Upon further questioning, the patient reports having 5 new dental caries or cavities during her recent dental visit. And while her vital signs are normal, you notice that on physical exam, there's a 1.5 centimeter submandibular palpable lump. The question could then ask which of the following labs could help confirm this patient's diagnosis. Well, based on all these signs and symptoms, the dryness the patient is experiencing, we talked about these up here, the lump on the neck could potentially be that B-cell lymphoma. They could throw this in subtly into the question. And so based on the information we have, this patient likely has Sjogren's syndrome. So which lab could be useful? Well, the autoantibodies that are associated with Sjogren's syndrome would be really helpful for confirming this diagnosis. So just a quick summary to wrap up this video. We're talking about Sjogren's syndrome. It's a type of autoimmune condition. What happens? We have overactivation of the immune system, leading to lymphocytic infiltration, destroying some of our glandular tissue. We're going to have a lot of presentations of dryness, right? Dry eyes, dry mouth, and dry skin. Be sure not to confuse this with age-related Sicca syndrome. We talked about some of the key ways to differentiate the two right here. When we think about diagnostics, you have to know about these autoantibodies, the anti-Ro and anti-LA antibodies, and some of the other non-specific ones that we can see in other immune conditions as well. There's a bit of overlap between these, so they're not as useful when making a formal diagnosis. Also keep in mind there are a couple different ways, such as a biopsy or the Schirmer test, we can use to, again, further confirm our diagnosis. When we think about our management here, it's really symptom management, but in severe cases, we can consider immunosuppression or glucocorticoids. Important to keep the key complications in mind. These include the increased risk of B-cell lymphoma, corneal damage, and neonatal lupus for these patients. Welcome back everybody, David here again with Med School Boot Camp. So in this next video, we are going to talk about a condition called antiphospholipid syndrome. So antiphospholipid syndrome, sometimes shortened to APS, is an autoimmune disease that is associated with an increased risk of thrombosis due to the presence of procoagulation antibodies. So if we jump into the pathophysiology here, we can see that we have an increased production of antiphospholipid antibodies that leads to increased activation of platelets, decreased activation of anticoagulant proteins, and thus hypercoagulable state and an increased risk of thrombosis. And this should make sense to us, right? Think about our basic hematology, right? Activation of platelets and less anticoagulants is going to lead to a prothrombotic state, increasing the patient's risk to having thrombosis in various areas in their body. Now, this can occur for a variety of different reasons. One, it can be idiopathic. That is to say, we don't know specifically what the cause is for this. However, in other patients, or secondary causes can include underlying conditions such as lupus or SLE, most commonly, rheumatoid arthritis, HIV or hepatitis, bacterial infections, or neoplasms. So you can see there are a lot of associations that you might need to know. Maybe they'll give you a lupus patient, and you'll have to have the association in your mind that, oh, this patient can also have something like APS or antiphospholipid syndrome. Trickier iterations of this question could talk about a patient with HIV or hepatitis, and being able to know that these patients are also at an increased risk of antiphospholipid syndrome could be useful as well. A lot of times questions will ask you to make these connections between different types of pathologies when you're answering questions on test day. Now, if we think about the presentation here, we really want to focus on a few key points. One, this is more common in females than males, and there's an increased risk with age. They were also classically asked this question about a pregnant patient who has recurrent miscarriages. So let's think about this for a second. Why might somebody who has antiphospholipid syndrome or APS have recurrent miscarriages? Well, remember, if we think to our pathophysiology here, the primary problem is that we have a hypercoagulable state and an increased risk of thrombosis. Somebody who's pregnant who has this increased risk can lead to a thrombosis that actually leads to placental infarction, thus predisposing them to the miscarriage. Now, we might also see this present as a variety of other different vascular abnormalities. These include things like DVTs, PEs or pulmonary embolisms, myocardial infarctions, MIs, stroke, or this unique finding called levator reticularis. And so if you draw your attention over here, this is a classic image of levator reticularis. And you can see this kind of purple, reddish, lace-like is kind of how they describe it in questions, finding on the skin. So you can appreciate kind of the clear white skin here and then kind of these purple findings in the lacy-ish appearance. And now the reason we think this occurs is again due to the hypercoagulable state. It all comes back to the pathophysiology here. Patients who are hypercoagulable are likely to be throwing clots in their venules in the venous system. This can lead to an obstruction and backup of blood flow, ultimately presenting as kind of this dark purplish reddish appearance on skin. Now, let's turn our attentions to the diagnostics here because this is super important for this condition. And the primary thing I want you to know is that on a coagulation panel, we're going to have increased partial thromboplastin time or PTT. And the reason for this is primarily due to something called the lupus anticoagulant. So as the name suggests, anticoagulation indicates an elevation of the PTT. This should make sense to us. But as we'll see shortly when we talk about the mixing study, this is a little bit different when we're talking about an in vitro sample versus in vivo. That is to say, looking at the antibodies in a laboratory setting versus what they actually do in the body themselves. So we'll wrap back around to that in just a second. We'll also see some other findings in these patients such as thrombocytopenia, leukocytopenias, and plus or minus hemolytic anemia. Now again, the key players here are going to be the autoantibodies, the lupus anticoagulant, the anticardiolipin, and the anti-beta-2 glycoprotein. One key point I want you to know here is that the anticardiolipin can cause a false positive RPR-VDRL, which we know is used to diagnose syphilis. We've talked about this in a few different videos now, right? These tests to diagnose syphilis can be used. However, there are a lot of other things that can cause these tests to be positive as well. So you really have to take the clinical picture and think about the test is not pathognomonic for syphilis, right? If somebody has an RPR and VDRL, that doesn't for sure mean they have syphilis. There are a variety of other things that can cause a false positive result. Antiphospholipid syndrome is one of them. So now let's try to make sense of this increased PTT despite patients having a prothrombotic state. And to really understand it, we have to understand something called the mixing study. And this is where we mix patients' plasma with normal plasma or clotting factors. And again, I put a high yield here because I love to test about this concept because it doesn't necessarily make sense intuitively. We have to know this principle on test day. So here's how we're going to do this. We're going to do something called a mixing study. And so the way the mixing study works is we're going to combine the patient plasma with normal plasma. And so if we combine these two values, right, we might have the patient's plasma, which could have the presence of the lupus anticoagulant, but the normal plasma would not. And so if we put these two together and we measure the PTT, or we measure the coagulation time, and it's normal, this means it's unlikely to have the lupus anticoagulant factor. However, if the PTT remains prolonged, this indicates that there could be the presence of the lupus anticoagulant. Why? Because something that's an anticoagulant is going to prolong the PTT. It's going to prolong the coagulation cascade. So again, just to summarize, if we don't have the lupus anticoagulant, we wouldn't expect prolongation of the PTT. We'd expect a normal value. But if we mix the serum with somebody who has a lupus anticoagulant, we expect a prolonged PTT in these patients because they have a molecule, an anticoagulant molecule that would prolong the coagulation time. Now we have to take a little bit of a bigger picture on this. We're saying that PTT increases, which would indicate that patients should bleed, but we're saying that patients are prothrombotic. So why is that? The reason for that is in the laboratory setting, when we take out plasma and we do things in a test tube, this is called in vitro. When biomechanical processes are happening in the body, we call that in vivo, and things act differently. And here's why. So even though we call this a lupus anticoagulant, it only acts as an anticoagulant in vitro in the test tube, but in the body it's actually procoagulant. And so the name is a bit of a misnomer. And the reason for this is that in the body we have platelets. And this is important because the platelets activate the coagulation factors. We have that in the body. And activation of the coagulation factors can lead us to clot. It can lead us to have the hypercoagulable state and the increased risk of thrombosis that we talk about with this condition. But in vitro, right, when we're just talking about in the test tube, we mix the patient's plasma with normal plasma. In this combination of plasma, it doesn't have a bunch of platelets which would activate the coagulation cascade. And that is why in the test, we see the increased PTT. It appears that we're increasing the coagulation time. But in reality, when we talk about the body, the key difference is we have platelets in the body, and that changes the reaction because we get activation of the coagulation cascade. So again, these patients have a hypercoagulable state, and the name lupus anticoagulant is a misnomer because in the laboratory setting, when we test these patients, it appears to be an anticoagulant. But in reality, in the body, it is actually a procoagulant overall. So we have to keep that in mind, and we have to know that because they can test you very easily on test day because it's not intuitive. You have to understand the laboratory findings and how we actually get these values so that you can get your questions right on test day. So again, key thing here, if the PTT normalizes, that indicates a lack of lupus anticoagulant, and if the PTT remains prolonged, that indicates the presence of anticoagulant. But again, this is in a test tube setting. In the body, it's an opposite effect, where we're actually putting patients in a procoagulant state. Now, if we move on to the management here, we obviously want to treat patients acutely if they are presenting with a DVT, a PE, MI, stroke, etc. But we can also do primary thrombophilaxis, and these are going to include things like aspirin, warfarin, and heparin. Key patient population, right? In pregnancy, we want to avoid warfarin. We know that it's teratogenic, and so the combination of aspirin and heparin is more likely to be used in these patients. Additionally, we want to avoid things that can make this condition worse. So we know that these patients are procoagulant at baseline, so we want to avoid other things that can worsen their procoagulant state, and that's going to include avoiding things that contain estrogen because we know estrogen increases the risk of thrombosis, and again, we're compounding the effect with these patients already having the increased risk of thrombosis. So a potential way they might ask about this on test day includes something along the lines of a 32-year-old patient presents to the clinic after her third miscarriage. The patient has good overall health, but does have a history of 2 deep venous thromboses in the past. Vital signs are normal, but on physical exam, you notice a reddish-blue net-like skin discoloration on the lower extremities. The question can then ask you, which of the following is the most likely reason for the patient's recurrent miscarriages? They could give you a lot of different things that can cause a miscarriage. They can talk about chromosomal abnormalities, they can talk about idiopathic occurrences, but given this patient's recurrent history, they've had multiple DVTs, they've had 3 miscarriages now, it's likely that they potentially have a condition that would cause this to happen. In this case, it can be antiphospholipid syndrome. So just a really quick summary of this video, antiphospholipid syndrome, or APS, is due to an increase in the antiphospholipid antibody that leads to a hypercoagulable or procoagulant state. This can be associated with a variety of different conditions as well. Presentation is typically going to be in females, particularly in pregnant females is how they like to ask about it on the boards because they're going to present with recurrent miscarriages. Patients can also present with DVTs, PEs, MI, strokes, or livedo reticularis, a pretty unique physical exam finding. We're going to see an increased PTT on diagnostics, and this is due to the lupus anticoagulant. Remember, we specifically talked about this is a misnomer. It's an anticoagulant in a test tube setting, but in the body, it's actually a procoagulant effect. This is due to the platelet activation of the coagulation factors. And so really important to keep in mind this mixing study and what it would show you if a patient is likely to have lupus anticoagulant or not. Now, when we think about the management here, we're thinking about thrombophilaxis. We don't want patients to have these presentations, right? So we're going to treat them with things that can decrease the likelihood of this happening, including aspirin, warfarin, or heparin. Key patient population here in pregnancy, we want to avoid warfarin because of its teratogenicity, and thus we're going to stick to aspirin and heparin. Also, we want to avoid making these patients further hypercoagulable by avoiding things such as estrogen that can increase the risk as well.
Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about another rheumatic condition called polymyalgia rheumatica. And from the name, you can probably understand that this condition deals with poly or many myalgias or muscle pains, in addition to rheumatic conditions, which affect the joints and the tissues. And so this is a type of inflammatory condition that a patient can present with kind of generalized pain that is related to the immune system being overactive. So if we look at our pathophysiology here, we can see that overall this is a fairly poorly understood condition. We don't really know the interactions biochemically of what's going on, but it's due to an overactive immune response, which leads to increased inflammation. We know that increased inflammation in the body is going to cause pain and tenderness for a lot of patients for a variety of different things. And so these patients are experiencing a normal response where there's increased inflammation in the body. This can present as pain or other systemic signs such as fevers. And if we look at our associated conditions here, really important to know is this association with giant cell temporal arteritis, or GCA. If you recall, giant cell temporal arteritis is one of our vasculitides. Specifically, it's a large vessel vasculitis, of which we're going to have an entire video covering in detail. But just a general review, these patients are typically middle-aged women, usually over 50, that can present with unilateral headaches, potentially jaw claudication. And this is really important because these patients have an increased risk for blindness. A very classic question is, if you suspect giant cell temporal arteritis, what do? Get the biopsy or give steroids? You give the steroids first because the risk for blindness is so high in these patients. We don't want to go down that route. So again, it's high yield for you to know these associations, because sometimes they will ask you questions. They'll give you a very classic patient presentation. Let's say they're talking about giant cell temporal arteritis. You're able to pick this out because the patient presents with unilateral headache. They're kind of in the right age range, and they ask you what's an associated condition. Well, the answer for that question could be polymyalgia rheumatica. They might ask it in the way of, what else is likely to be seen in this patient's history? Again, this is a way for them to see, do you know which conditions are associated with one another, and thus a patient could potentially have both if they were to show up in clinic or the ED or whatever the environment is. And so keep that in mind as a high yield concept. When we think about this patient's presentation, we already touched on some of them, but here we're also going to be dealing with a higher likelihood of females being affected than males and an increased risk with age. So again, both of these have a similar presentation. Both the GCA along with PMR are going to have a similar presentation. More common in females, but that doesn't mean it's exclusively in females. So we have to be mindful of that in the clinical setting. Anyone can actually show up with this presentation. Patients can also have systemic signs, and this makes sense, right? Because we talked about this as an inflammatory reaction. So things like fever, fatigue, night sweats, weight loss are all things that can be present. Why? Because they increase inflammation throughout the body in this condition. Patients can also have musculoskeletal problems, including stiffness and pain, particularly in the neck, shoulders, trapezius, and pelvis. This is typically worse in the morning. Now, key point here, this does not typically present with weakness. So this is an inflammatory problem, right? It's painful, it might be stiff, it hurts, but patients are not dealing with neuromuscular junction problems, right? They're not dealing with things that can cause weakness. And so this is a really important point, because they'll talk about this in the question set. They'll say the patient is having difficulty standing from a chair because it hurts or because they're stiff, but they're 5 out of 5 strength on muscle testing. That's an important distinguishing feature versus something else where they might be 4 out of 5, which is to say there's a weakness with the muscle testing. This can indicate some other pathologies, again, like neuromuscular junction problems, or potentially just generalized deconditioning. Now, when we think about our diagnostics here, it should make sense to us that this can often be a clinical diagnosis, right? We talked about some classic signs and symptoms. We want to rule out scary things that could be going on with these patients, but if they're presenting with this classic way, they might actually have polymyalgia rheumatica. We can also see some lab findings that are kind of unique here in our serum labs, in that the ESR and CRP is elevated. This should not be a surprise, because we said this is an inflammatory condition, and these are inflammatory markers. But we will see a normal creatinine kinase, and this is again indicative of the pathology or the pathophysiology here. There's inflammation, but there's not muscle damage going on, right? There's no reason that we should have weakness, because if muscle damage is not being done, creatinine kinase should not be leaking out into the body. We should not see an elevated level on the serum labs. And this is really important for comparing and contrasting some similar conditions, to look at the serum labs. Particularly when we look at our inflammatory markers, our ESR and CRP, we'll talk about in a different video a condition called fibromyalgia, which can present with a lot of similarities. However, in this condition, we would not expect increased inflammatory markers because it's not due to an increased inflammation in the body itself. So again, compare and contrast. This has increased inflammatory markers because there's increased inflammation. In a condition like fibromyalgia, we don't have the increased inflammation. That's not what's causing the problem, and thus we would not have increased inflammatory markers. Similarly, we have conditions like polymyositis and dermatomyositis, in which we would see a change in the creatinine kinase levels. We might see elevated levels, but here we're not seeing that. So again, to compare and contrast polymyalgia rheumatica versus polymyositis or dermatomyositis, separate videos on those pathologies, looking at these labs, particularly creatinine kinase, is going to be useful in our ability to compare and contrast these pathologies. Finally, we have some serology that we can look at. However, there's no specific antibodies, and these patients likely have a negative rheumatoid factor. We've talked about in many of these videos, some of these autoimmune conditions, we look for specific antibodies in the body to tell us yes, this patient likely has this condition, but here we don't really have that luxury. So it's really a clinical diagnosis with some serum labs that can be useful when making a diagnosis for these patients. When we look at the management here, fairly simple. Patients tend to respond to low-dose glucocorticoids. This kind of helps calm down the inflammation, the inflammatory response in the body, which again, we said our pathophysiology, that's the main problem here. And thus it makes sense that giving glucocorticoids or calming down this system can be useful for these patients going forward. So a possible vignette they could ask you for this question includes a 55-year-old woman presents to the clinic with a chief complaint of increasing fatigue as well as pain in her hips and shoulders. The patient reports intermittent night sweats and 10 pounds of unintentional weight loss over the last month. On physical exam, you notice she has 5 out of 5 strength in the bilateral upper and lower extremities with generalized tenderness over both of her deltoid muscles. Vital signs are within normal limits. You decide to get some labs and notice that she has elevated ESR with a normal creatinine kinase. The question then asks you which of the following is a patient's most likely condition. Well, based on this video, right, the correct answer would be polymyalgia rheumatica. But again, they can give you some other answer choices. They could give you polymyositis. They could give you dermatomyositis and fibromyalgia. All 4 of these conditions have some similarities with how a patient would present. But the key here for answering this question is that this patient has elevated inflammatory markers, likely making fibromyalgia less likely, as well as a normal creatinine kinase, likely making polymyositis and dermatomyositis less likely as well. So again, as you're learning this content, keep in mind these compare and contrast things for getting questions right on test day. So just a quick summary of this video to wrap up. We have polymyalgia rheumatica. It is a poorly understood condition that has overactive immune response leading to increased inflammation. So that's what's going on. Widespread increased inflammation. This is associated with GCA or giant cell temporal arteritis. High yield point to remember. It's going to present with things that we would expect to see in somebody who has too much inflammation in the body. Systemic signs such as night sweats, fevers, fatigue, as well as musculoskeletal things such as pain, stiffness, particularly in these groups of muscles right here. Now, notice it's not typically present with weakness. However, technically in the chronic long-term, right, patients could stop working out. Because of the pain and stiffness, this could technically lead to weakness down the road, but in the early stages, it's not really how it presents most commonly. So when we think about our diagnostics here, it's often clinical, but we have some labs to help us out, including inflammatory markers, but a normal creatinine kinase. We can also look at serology, but there's not really a clear-cut autoimmune antibody to look for, and thus this is actually less helpful overall. Management here is going to be low-dose glucocorticoids, which makes sense. Why? Because the problem is inflammation, and we want to settle that down. We want to calm that down to try and improve the patient's symptoms. Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we're going to talk about a condition called fibromyalgia. So fibromyalgia is important because we have to compare and contrast it with some other similar conditions, such as polymyalgia rheumatica, dermatomyositis, polymyositis, rheumatoid arthritis. There's a lot of different conditions that fall under this category. And so when we're comparing and contrasting these conditions, we have to be able to say, what are the differences in patient presentation? Maybe patient's age. Are the labs any difference? What kind of things can we use to differentiate these similar but different distinct pathologies? So if we look at the pathophysiology here, again, with fibromyalgia, it's poorly understood what the actual pathophysiology is, but it's a non-inflammatory musculoskeletal presentation, or patients will have non-inflammatory musculoskeletal symptoms. And so that is to say, patients are having real symptoms. They have neurosensory symptoms where they're feeling things, but it's not due to muscle inflammation. It's not due to systemic inflammation in the body itself. So when we look at our associated conditions here, there's a few things to be mindful of. Fibromyalgia is more common in patients with somatic conditions. These include things like irritable bowel syndrome, migraines, chronic fatigue syndrome, as well as psychiatric conditions, such as generalized anxiety disorder and depression. Now, it's important to note, just because there's an association with these things doesn't mean patients are making them up, right? It's not in their head. It's a real physical manifestation. They're really feeling the symptoms, but we don't always have a clear explanation as to why. Pain is a very interesting thing in that pain itself is a body's perception of what they feel. And so that's a thing to be mindful of. Just like patients have different heights, they might have different pain tolerances, or they might perceive that pain differently. And that's sometimes what we're dealing with here in fibromyalgia. So it's important to keep this in mind. When we think about classic presentations, this is more common in women and typically presents around 20 to 50 years of age. Patient can have systemic findings such as headaches, fatigue, poor sleep, or cognitive changes. If this is due to fibromyalgia, we often call this fibrofog. And this can be due to a variety of different things, but one of the key things to note here is that a lot of times patients who have fibromyalgia also have poor sleep, or they have sleep disturbances. Poor sleep, we know, can lead to kind of these cognitive changes or this fogginess, right? If we haven't had sleep for several days, we all kind of feel foggy. Well, patients with fibromyalgia might consistently have poor sleep, and thus it makes sense that they could have these foggy symptoms or cognitive changes that they are noticing. Now, they also have musculoskeletal things such as diffuse pain with tender points as well as paresthesias. Keep in mind, these patients shouldn't generally have weakness. It's really the tenderness, it's the pain, it's that perception or the dysregulation of the brain's response to how the body is feeling. But again, they shouldn't have the weakness that we
we might see in some other conditions that we've talked about previously. Additionally, when we talk about the diagnostics here, this is again really important to note that this is often a clinical diagnosis. Particularly, there is some criteria to make this diagnosis, which include things like having the symptoms for greater than 3 months, pain that affects all quadrants of the body, so it's not localized to just the right shoulder, right? That might be something else going on. It's more widespread, it's more diffuse, and these profuse tender points on examination. Now, a really important thing to know for these patients is that the labs, for the most part, are going to be normal. So if we get some serum labs, we're going to have normal ESR or CRP and no specific autoantibodies. Why are the inflammatory markers normal? Well, again, the pathophysiology is that this is a non-inflammatory musculoskeletal condition. Contrast this with polymyalgia rheumatica, in which we talked about it being an inflammatory musculoskeletal problem, thus we would see increased inflammation markers. We also will see no significant changes on the imaging, and so sometimes patients will have neck pain, shoulder pain, pain in the trapezius. You'll get some x-rays, maybe thinking they have arthritis in their shoulder, or maybe even an MRI thinking they have rotator cuff damage, and everything will be completely normal. We do not expect to see actual damage to the structures if the patient truly has a condition of fibromyalgia. When we look at our management options here, it includes things like exercise, which is super important. And this one is kind of tough for patient education, right? They're in pain, they hurt, and you tell them to exercise, to go get out there and go for a walk, which is painful for them. It's very challenging to be able to do that when you're not feeling well. And so this is sometimes something that we really need to educate the patients on. That regular physical activity is actually beneficial for this condition, and it can actually improve the symptoms and help patients feel less of the pain in the long run. We can also consider some other things such as antidepressants, particularly duloxetine and amitriptyline, which is a TCA. We can also consider some neuropathic pain medications such as gabapentin or pregabalin. Important to note here, you want to avoid opioid medications for pain control. We often think about using opioids for pain control, but this is for specific patients in specific scenarios. Fibromyalgia is more often a chronic condition, and we don't want to give chronic opioids to patients for their pain, right? Particularly because their pain is not due to musculoskeletal problems. It is more so due to the perception or the association of pain with various areas in the body, including these tender points that we talk about right here. So again, these medications have been shown to be helpful for these patients, but regular physical activity has also been shown to be extremely helpful and is going to be the option that has the least amount of side effects for the patient. So a possible vignette they can give you includes something along the lines of a 45-year-old woman presents to the clinic with a chief complaint of headache and neck pain. The patient reports she's been having symptoms for years now, and she has been to many doctors without improvements. Vital signs are within normal limits. On a physical exam, you notice the patient has a very prominent tenderness in the upper trapezius muscles, as well as the greater trochanter area near the hips bilaterally. You order some lab studies and see that the ESR, CRP, creatinine kinase, and electrolytes are all normal for this patient. And the question then asks you which of the following is the best treatment option. Well, if they give you exercise as an option, that would be a good choice. But if they give you pharmacologic things, you want to consider things like antidepressant medications or neuropathic pain medication. You do not want to consider the answer that gives opioids as an answer choice. That would be incorrect in this situation. That is not the treatment option for patients with fibromyalgia. So a quick recap of this video: fibromyalgia is poorly understood, but it's a non-inflammatory musculoskeletal problem, thus presents with non-inflammatory musculoskeletal symptoms. It can be associated with somatic or psychiatric conditions, but again, this doesn't mean the patient's not really experiencing this symptoms. They really are, but these are some key associations that you need to know about as well. When we think about the presentation, there's quite an age range here, but it's more common in women. They're going to have a variety of systemic findings such as headache, fatigue, or this fibrofog characteristic, as well as musculoskeletal things, particularly these tender points and paresthesias as well. Typically, this is a clinical diagnosis, but if you do pursue further testing, you will see that the serum labs are going to be normal and no imaging changes should be noted as well. Management is going to include conservative measures such as physical activity or exercise. However, there are some pharmacologic interventions, including antidepressants and neuropathic pain medications that can be used for these patients. Again, super high yield. Avoid opioids in these patients. We don't want to start them on chronic pain medications for this condition.
Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about two separate but similar conditions called polymyositis and dermatomyositis. Now, these are types of idiopathic inflammatory myopathies or muscle conditions that can lead to inflammation and progressive weakness. And when we think about this condition, we really need to have a pretty broad differential when patients kind of present with non-specific symptoms. So things that we should consider in addition to these pathologies include fibromyalgia, polymyalgia rheumatica, drug-induced myopathies, hypothyroid myopathy, muscular dystrophy, or potentially even neurological things like ALS or myasthenia gravis. So again, we have to think about a broad differential, but I really want to focus on this view. How do we specify
identify, how do we determine that, no, this patient has an inflammatory muscle myopathy that's more consistent with dermatomyositis or polymyositis? So if we draw our attention to the pathophysiology here, we can see that this is an autoimmune inflammatory myopathy that leads to progressive muscle weakness plus or minus cutaneous involvement. This is typically going to be seen in dermatomyositis. Again, when we talk about differentiating these conditions, they're really similar, but dermatomyositis, remember our root word's derm, right, is related to the skin. So polymyositis deals with a lot of muscle things. Dermatomyositis deals with those muscle things in addition to the cutaneous involvement. Of less importance, but another way to differentiate the two is to know the way in which they cause the inflammation. So polymyositis is cell-mediated cellular damage. That is, it goes directly cell to cell and damages the muscle or the tissue surrounding it. And then we compare that with dermatomyositis, which is more antibody-mediated cellular damage. That is to say, it's the formation of antibodies that then go directly and damage the cells. And this is more associated with malignancies such as non-Hodgkin lymphoma, lung cancer, stomach cancer, or it can be idiopathic as well. And this brings us in nicely to our next point, talking about our associated conditions. So these can be associated with things like malignancy, and we just talked about that, right? Because we can have antibody-mediated reactions that lead to cellular damage. This can also be associated with esophageal weakness, and this is related to the fact that we get muscle weakness from these conditions, right? We get inflammation and damage to the muscle tissue that can lead to weakness of the striated muscles that are in the esophagus. This can lead to further complications such as aspiration pneumonia. So we have to keep this in mind. It's also associated with myocarditis, which can obviously be very serious and lead to arrhythmias and respiratory failure as well. And again, this is related to the muscle weakness, right? Our diaphragm helps us breathe. If we're not able to breathe as well, we can get respiratory failure. We can also develop interstitial lung disease. So we have to keep this in mind. Damage to the muscle tissues can present in a lot of different ways. It's not just in the muscles we think about working out at the gym, right? Our diaphragm is a muscle. Our esophagus has muscles in it. Our stomach has muscles in it. We have to think about all of the muscles in the body that can be affected in these conditions. Now, when we think about the presentation here, really key way to differentiate the two is that polymyositis has symmetric proximal muscle weakness and myalgias, typically in the shoulders. So these patients are going to present saying, hey, I can't brush my hair as well. I can't put my shirt on. Why? Because I'm very weak in my shoulders. I need my shoulders for these overhead motions, and now they're weak. Some other symmetric muscles include the pelvic girdle, right? I can't walk upstairs. I can't get up from a seated position quite as well. These are areas that are mostly affected in this condition. And again, differentiating polymyositis versus dermatomyositis, lots of similarities here. But in dermatomyositis, we see the similar symmetric proximal muscle weakness and myalgias, but we're also going to see the cutaneous involvement. I put this as high yield because this is how you differentiate the two. If they're talking about skin rashes or presentations plus this proximal muscle weakness, that's more indicative of dermatomyositis. Again, derm meaning related to the skin. So some key physical exam findings they're going to want you to know here, including understanding the images, include the heliotrope edema, which you can see right here, Gauthran's papules, which you can see right here is kind of these red portions on the knuckles, mechanics hands, which you can see right here, look really worn out, as well as this particular type of rash called the Shao and V sign. So let's take a closer look at these images. And first up is the heliotrope edema or heliotrope rash. And you can see this around the eyes. It's kind of this reddish appearance on the upper and lower eyelids. And the term heliotrope is referring to a type of flower that kind of has a reddish purplish appearance. And that's what they're trying to describe here on the patient's eyelids. And now here in our next image, you can see the Gauthran's papules that we were talking about previously. So these are the really red, well demarcated findings, particularly around the knuckles. We also talked about the mechanics hand. So you just think about a mechanic, right? They're really worn out, really crusty, dry skin to their hands can also be seen in dermatomyositis as well. And finally, the last key one that we want to know is the Shaw and V sign. So again, this is a rash on the chest that kind of has a V-shaped appearance. And this often appears in regions that can be sunburned, right? So on the chest, around the neck, this is where the patients are likely to present with this. Again, the reason these are so important because it helps differentiate polymyositis versus dermatomyositis. We have all these different physical exam findings, right? We have the heliotrope rash, the Gauthran papules, the mechanics hands, and the rash that can indicate this patient has dermatomyositis versus polymyositis. Now, when we think about our diagnostics here, the key autoantibodies I want you to know are the anti-Jo1 antibody, also called the histidyl tRNA synthetase, anti-SRP or signal recognition particle, and the anti-MI2 or helicase molecule. Because sometimes they will give you a presentation, right? They'll give you a very classic presentation of dermatomyositis, and they'll ask you which of the following antibodies is associated with it. So at this level, you need to kind of have these associations, and this is where our spaced repetition or our memory aids can be really useful for keeping these in mind. We can also think about some non-specific serology. These include things like rheumatoid factor and anti-nuclear antibody. Remember, ANA is pretty non-specific. We see that in a lot of different rheumatologic conditions, and rheumatoid factor does not necessarily mean a patient just has rheumatoid arthritis. We can also see rheumatoid factor in a variety of other rheumatologic conditions, including polymyositis and dermatomyositis. Now, when we think about our serum labs here, we can have a normal or elevated ESR and CRP. Remember, these are inflammatory markers in the body. We're typically going to have an elevated CK. This is creatine kinase. And think about why this is. Well, the pathology here is damage to the muscle tissue. We know creatine kinase is found in the muscles, and so damage to the tissue can release the CK into the body, and we can measure that on serum labs. We'll also see an elevated aldolase, myoglobin, and LDH for similar reasons. Because when we have damage to cellular tissue, some of the enzymes that are in the cells get released into the body and can be actually measured on our serum labs. Now, another key thing they like you to know here is about the muscle biopsy. So in polymyositis, you get endomysial infiltration with CD8 T cells, and in dermatomyositis, you get paramysial inflammation with CD4 T cells. And so just as a quick refresher, right, if we have a muscle cell bundle, we have the surrounding tissue called the epimysium. Then we have the tissue that surrounds each bundle of muscle fibers called the perimysium. And finally, we have the endomysium that surrounds each individual muscle fiber itself. And so in polymyositis, we're talking about endomysial inflammation. And in dermatomyositis, we're talking about paramysial inflammation. Something they also like you to know is about what T cell markers would you expect to see. So in polymyositis, you typically expect to see CD8. And in dermatomyositis, you're more likely to see CD4. Memory aid I use for this is poly means many, the root word many. So I think it's more of them, right? So 8 is greater than 4. And that's how I keep these straight in my mind for test day. So briefly, if we draw our attention to the histopathology of this image, we can see a bunch of cellular infiltrates in the muscle cell. So based on this image, which condition is this patient most likely to have? Well, this patient is most likely to have polymyositis because this is endomysial inflammation, right? You can see the individual fascicles of the muscles and all of the cells that are surrounding the endomysium as well. And also to wrap up the diagnostics, they like you to know that for patients diagnosed with polymyositis or dermatomyositis, it's important that they're tested for underlying malignancy. The reason for this is because there's an increased association with malignancy in these patients. Now, if we move on to the management here, we're going to see that this mostly deals with using glucocorticoids plus or minus steroid-sparing medications such as methotrexate or azathioprine. We're really trying to calm down the immune system, right? We talked about this being an autoimmune inflammatory condition, and so giving steroids is a way that we can calm down the immune system. Obviously, there are pros and cons of this medication, so it's a risk-to-benefit analysis, but this is the primary way that we're going to treat these patients. So a really simple and classic way they might ask this question is to say something along the lines of a 50-year-old patient presents to the clinic with a chief complaint of weakness climbing stairs and combing her hair. The patient also reports new onset of redness around her eyes that she thinks might be worsening over the last several weeks. The vital signs are normal in physical exam, but then the question could ask you, which of the following might you expect to see on muscle biopsy? So yes, it's giving you a very obvious presentation of dermatomyositis, but they want you to know the different levels. And so it could ask you about the different T cell markers, right? It could ask you to differentiate CD4 versus CD8 on muscle biopsy, or it could talk about the different areas of location. Is it paramysial or is it endomysial? And so these are ways they can test your connection. Do you understand the deeper levels of diagnosing this condition? And do you know which association goes with which pathology? So real quickly, just to wrap this up and summarize the video, polymyositis and dermatomyositis, these are autoimmune inflammatory myopathies, right? Progressive muscle weakness. The key differentiating step between the two is really going to be the classic dermatologic findings. We talked about some key associations here. And again, this has to do with the fact that muscle weakness is not just the muscles that we lift in the gym. It's our diaphragm, it's our esophagus, it's all the muscles in the body that can be affected. And that's why we have some of these associated conditions. When we think about our presentation here, right, it's going to deal with the proximal muscle weakness, typically the shoulders and the pelvic girdle, although there are some exceptions to that rule. If it's dermatomyositis, you're going to see a lot of these classic physical exam findings that we talked about, right? A lot of skin findings. And so it's important to keep that in mind on test day, whether or not they're giving you skin presentations or not. When we think about our diagnostics here, right, we're dealing with some really important antibodies they want us to know, but they often focus on the muscle biopsy and the differences that you'd see between these two conditions. And finally, when we talk about our management here, we're really going to think about using glucocorticoids and other things that can suppress the immune system. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about a condition called myositis ossificans. And this is not a very commonly tested condition, but if it does show up, I want it to ring bells in your head so that you can get the easy points on test day. So when we think about the pathophysiology here, we're dealing with a condition that has repeated or blunt trauma/damage that leads to heterotropic ossification of skeletal muscle. So let's break this down a little bit. Repeated damage over time to the soft tissue can lead it to become ossified. Ossified meaning that it becomes a bony formation. And so myositis ossificans is essentially heterotropic ossification, which is a benign ossification of the soft tissue or bony formation of the soft tissue. Now, when can this occur? Well, we talked about it can occur in blunt trauma, but it can also occur with a lot of overuse injuries. And so these are the two key ones that you need to keep in mind. So it can occur in athletes, let's say as a football player that continuously gets tackled in the thigh. It would be reasonable that over time this soft tissue could develop bone formation or heterotrophic ossification. Another way this could happen is somebody who has a traumatic injury. So if they're in a car accident, if they get surgery, anything that traumatizes the tissue, the soft tissue around a joint or various locations in the body, can then become a bone formation or become ossified over time. And these are going to be some of the classic ways they'll ask about it. It can be an athlete that has overuse injuries or traumatic injuries that can occur in a variety of different ways. Now, when we draw our attention to the presentation here, it's going to present as painful soft tissue mass. It can present as local swelling, tenderness, and a decreased range of motion. So think about it, right? If we have soft tissue that now has bony formation around it, what's that going to do to the range of motion? Well, it should restrict that range of motion. It should make sense, right? If we have a bunch of bone forming around the knee, we shouldn't be able to move the knee as much compared to when we have the soft tissues. Now, the tenderness and local swelling is because this is often due to trauma or damage to the area, so this should make sense to us, right? The findings that the patient can present with align with the pathophysiology or the thing that causes this pathology to develop should be able to make sense to us why a patient would present with these findings here. Now, when we turn our attention to the diagnostics, the serum labs are going to have elevated ESR and alkaline phosphatase. And remember, ESR is one of our inflammatory markers, and it can be elevated in a lot of different conditions, so it's fairly nonspecific in general, but we can see that lab. Additionally, alkaline phosphatase is another lab that we tend to see, particularly with bone pathologies or gallbladder pathologies. Those are kind of the two things that they're going to talk about this enzyme being elevated in the serum. And so here we have a bone pathology. Another key one is Paget disease of the bone, where we can see this elevated alkaline phosphatase level. If we think about imaging, we're classically getting an X-ray that shows peripheral bone formation with soft tissue calcification. And so if you draw your attention over here, you can see a normal elbow X-ray with some hardware that's been put in for this patient. Now, over time, this is a traumatic event. We put hardware into the body, the surgery to get to the bone. We put something in the bone. This can cause trauma to the area. And we see this calcification that is developed, right? This is a soft tissue area. You think about the front of your elbow. There's not a bunch of bones poking out of it. You have your main bones in your humerus, your radius, and your ulna in the forearm, but we don't really have other bones that are surrounding. We don't have small bones in the area. But here we can see this is what the soft tissue looks like. It's a much darker appearance, but this is the calcium, right? This is the calcium deposit. This is an example of heterotrophic ossification. Now, when we think about the management here, it's primarily just going to be symptom management. This can include things like rest, activity modification, and physical therapy. Often this is a self-limiting condition. What does that mean? That means that over time the body can actually resorb the calcium. It can actually fix itself over time and repair the affected area. However, if it's not self-limiting and the conservative measures do not work, we may have to consider surgical intervention if the patient is having refractory symptoms that are not improving over time. Now, the main thing they're going to trick you with here is comparing and contrasting this with a sarcoma in the bone. A sarcoma is a malignant mass that arises from mesenchymal cells, and it can potentially appear similar on an X-ray finding, but the history is going to be a lot different, right? This is important because this condition right here, myositis ossificans, is a benign finding versus sarcoma is a malignant finding. And we're going to talk a lot more about primary bone tumors in a different chapter, but just keep in mind, what is the history of the patient, right? Does the patient have a history that's indicative of a cancerous growth, or is it more likely this presentation where the patient, has frequent traumas to the area, maybe a recent surgery at a joint that could be indicative of new growth of the bone or myositis ossificans? So a classic way they could ask about this is to give you a question stem that involves a 76-year-old patient who presents to the clinic with pain and stiffness in his right hip. The patient underwent a total hip arthroplasty 6 months ago, and although the pain and stiffness was better in the weeks after surgery, it has begun getting worse. Vital signs are normal. On physical exam, the patient has 5 out of 5 strength in the right lower extremity, with restricted hip motion on internal and external rotation. On X-ray, the hip is not dislocated, but there's increased ossification around the hip joint that was not present on the initial post-operative X-ray. The question can then ask you what's the most likely diagnosis. In this patient, again, a surgical exposure trauma to the area can cause the body to create bony formation. When it reacts to a certain stimulus, it creates this ossification, and this can create the pain and stiffness in the patient, particularly the X-ray finding that they did not have this near the time of surgery, but it's developed months and months later would lead this to being the most likely diagnosis. So just a quick summary to wrap up this video, a pretty short one overall. Myositis ossificans is due to repeated blunt trauma or damage to an area that leads to heterotrophic ossification. This is what we see right here. This can present as a painful soft tissue mass with swelling, decreased range of motion, and tenderness. The labs are most likely going to show you an elevated ESR and ALK-Phos, but the most important thing is to know the X-ray finding, where we can kind of see in an area we would expect there to only be soft tissue, this new growth of calcification right here. Management is going to include symptom management. This is often a self-limiting condition. However, if it persists over time, there are surgical interventions that can be taken as well.
Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about a condition called systemic juvenile idiopathic arthritis, sometimes also called Still's disease. Now, the pathophysiology of this condition is poorly understood overall, but it tends to show up in younger patients, often affecting males at an equal rate of females. This patient typically is in people younger than 16 with a peak incidence of 2 to 4 years old. So we need to think about that. When we're answering a question stem and they're giving us a patient presentation, keep in mind how old is the patient. Is it a 6-year-old patient or is it a 60-year-old patient? It's very important for us to know this because as we're building a differential diagnosis in our head, we need to know what kind of range are we in, what would we classically see in this age range for a patient, because that's how the boards are going to test you. They're going to test you on classic patient presentations. So we think about this in a younger patient, less than 16 years old, but notice that the peak incidence here is approximately the 2 to 4 range. Now, a couple key findings we need to notice are there going to be systemic findings, musculoskeletal findings, and some additional findings as well. So when we think about our systemic findings, it's going to talk about intermittent spiking fevers for the patient. And so if a patient comes in and they have a one-time fever, they've had a fever for a couple of days, it might be an illness that they're having currently. But if it's intermittent and it's coming and it's going and it's coming and it's going for a longer period of time, potentially even several weeks, that's more indicative of a bigger or systemic condition. In this case, it's important to know also that these children typically have arthritis involving more than 2 joints. This often affects the knee, ankle, or wrist. And this is, again, a unique constellation of findings. It's one thing for a child to have intermittent spiking fevers, but why would a child have arthritis? We typically think about that in an older patient population, right? That's our 50, 60, 70-year-olds who have the arthritis, often osteoarthritis. Maybe we're thinking about rheumatoid arthritis for a variety of different reasons. A patient who's 4 years old presenting with arthritis really doesn't make a whole lot of sense. But a patient who's 4 years old presenting with arthritis, this is the first thing that we should think about at this level, the systemic juvenile idiopathic arthritis. It would be incredibly unlikely that a 4-year-old could have osteoarthritis at that age. So really that's not something that would be on our differential. We're going to be thinking more of this condition right here. It's also important to note that these are kind of long-term symptoms. So symptoms typically last greater than 6 weeks in these patients. Again, this is not the kid that fell at recess and scraped his knee and now he has knee pain. This is somebody who has had arthritis for several weeks now, or maybe even months before they present to their doctor. And finally, some of the additional findings that we can see in these patients include uveitis, so that's inflammation of the uvea in the eyeball, this salmon-colored macular rash, which we can see right here on this patient. You can appreciate the color here, right? It's like these bright pink macular rash appearance, bright pink kind of salmon appearing rash that the patient has all over their body. And again, it's really important. We think about rashes in pediatrics, right? In children, there's a lot of different things that can cause them, some more serious than others. But if we see this constellation of finding, right, we see the rash in addition to the arthritis, maybe they're talking about this condition, right? Maybe they're not necessarily talking about measles or some other conditions that have different associated findings. We can also see things like hepatosplenomegaly and serositis as well. Now, when we think about our diagnostics here, there's not a ton of stuff we're going to use, but the serum labs would show elevated ESR and CRP. Why? Because these are our inflammatory markers. Anytime we have an inflammatory response in the body, which this condition is, we expect to see those numbers rise. We might also see that the patients have lower red blood cells and increased white cells. Additionally, there's some non-specific serology. If you were to do some labs, you might see a positive ANA and a negative rheumatoid factor. Again, these don't necessarily point us in the condition. So our diagnostics here are not the most useful part of working with this patient. It's really the history and the physical to get this presentation right here. Is this a classic presentation of a patient who has juvenile idiopathic arthritis, or do they have the symptoms that we've talked about here? Now, when we think about the management here, it's really going to be symptom management. So anti-inflammatories or DMARDs, which are disease-modifying anti-rheumatic drugs we talked about in the rheumatoid arthritis section. We can also use things like steroids to help with the immune response and TNF-alpha inhibitors as well. Now, keep in mind, some of these last options can have a variable response. So these don't always have great responses in patients, but it's things that we can try, right? Anti-inflammatories are good to use acutely, but for longer-term symptom management, right, we have to try some of these things. Even though methotrexate might not be a great medication for these patients, it's something worth trying to help relieve their symptoms. So I think the really high yield thing to take away from this video is going to be the presentation. They really want you to be able to recognize this condition in a question set. Again, they're not going to get in the nitty gritties of, what type of DMARD should you use, what type of TNF alpha should you use. There's a lot of controversy over this and it's not super clear what's the most efficacious management option, but recognizing the presentation is. And so with that, I'm going to share probably one of my favorite memory aids all time that I've ever created, and that is to remember the classic findings of somebody with systemic juvenile idiopathic arthritis. So I use the first letter of each word, that is S, J, I, A. And so in this memory aid, the S stands for the salmon colored rash, which we can see here. The J stands for jalapeno, and this is indicative of the spiking fevers, right? We think hot jalapeno. So we have the fevers that patients can present with right here. I, we want to think of uveitis or the eye manifestations that can occur. And A is for arthritis. So if you just remember SJIA, you can remember the classic findings that a patient will present with who has this condition. So a classic way they might ask this is to say something along the lines of an 8-year-old patient presents to the clinic with complaints of bilateral knee and ankle pain for 2 months. The patient reports the pain is worse after recess at school. Vital signs are normal in the office, but the mother reports the patient has intermittent fevers over the last several weeks. On physical exam, there is moderate right knee swelling and mild left knee swelling. And the notable labs include an elevated ESR and CRP. The question could then go on to ask you, which of the following findings might you expect to see in this patient as well, or which of the following findings would be associated with this patient? And one of the key ones that hasn't been given in the question set so far is going to be the maculopapular rash. So that would be the answer. If you determine that this patient has intermittent spiking fevers, they have some arthritis pains, right knee and ankle pain, particularly after recess, they have a constellation of findings that indicates they likely have systemic juvenile idiopathic arthritis. So another finding you could expect to see in the patient, or an associated finding, would be that salmon-colored macular rash. So just a quick summary to wrap up this video: systemic juvenile idiopathic arthritis. Really what I want you to take from this video comes down to what we see right here, the classic findings, but the pathophysiology is poorly understood overall. Our presentation is going to deal with a younger patient who has intermittent spiking fevers, as well as some joint pain, and some of these other findings, including uveitis, the maculopapular rash, hepatosplenomegaly, or potentially serositis as well. Labs here are not going to be as helpful for us. There are a few key things that we could see, such as elevated inflammatory markers, but again, this is not really going to be how we're going to make the diagnosis in this particular condition. Additionally, we have some non-specific serology like the positive ANA. Again, an associated finding, but not going to help us get the answer correct on test day. Management comes down to symptom management here. We can use anti-inflammatories, and there's a variety of other medications that can be used as well. However, the response can be variable, thus making this a pretty tricky condition to treat for patients. Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we are going to talk about a condition called Raynaud's phenomenon. And Raynaud's phenomenon is essentially an over-exaggeration of the vasoconstriction, particularly in the distal extremities. Think of our toes and our fingers. And this vasospasm can lead to a constellation of findings, which we'll talk about, which is going to decrease overall blood flow to the extremities. Now, if we think about the pathophysiology here, we can see that we have reversible vasoconstriction of arteries and arterioles that lead to decreased blood flow in the extremities and ultimately ischemia, right? If we have over-exaggeration or over-vasoconstriction of the blood vessels that lead to our digits, they're not going to get the proper blood flow. And so just as a general reminder, ischemia can happen in a couple of different ways. We can either have an obstruction that occurs, which is oftentimes what we think about when somebody has a stroke or other blockages in the body that lead to ischemia, but it can also occur if an organ is not getting enough blood for a variety of different reasons. If we have a blood vessel this size going to an extremity or an organ, and then we have excessive vasoconstriction, so now the blood vessel is this size, well, you can imagine that not as much blood can get through this new vessel as could get through this vessel. And this is another way that we can have ischemia present as well. We also have to consider the causes here, and that this is primarily an idiopathic condition. And sometimes this primary idiopathic condition is known as primary Raynaud's phenomenon or Raynaud's disease. Now, we can also have secondary Raynaud's phenomenon, which is previously known as Raynaud's syndrome. And this can be due to underlying diseases, medications, or hyperviscosity. So what are some medications? Well, we could be dealing with things like beta blockers. We can also be dealing with underlying diseases such as connective tissue diseases. One of the classic ones being scleroderma or the CREST syndrome. The R in the CREST syndrome is to remind us of the Raynaud's phenomenon. We can also see this in patients who have hyperviscosity. These include things like polycythemia or cryoglobulinemia, any condition that really thickens or increases the viscosity of the blood flow in the body. Now, if we draw our attention to the associated conditions here, we already mentioned the association with scleroderma and CREST syndrome, but this can also be seen in SLE and MCD as well, which is mixed connective tissue disease. Additionally, we have our hyperviscosity syndromes. When we think about our presentation here, this is typically going to affect the distal digits for about 10 to 20 minutes. These include things like the fingers or toes. And why might these be more likely to be affected? Well, because our distal digits have less collateral vascular structures, they also have smaller vessels overall, right? So if we have vasoconstriction of our aorta, we still have a ton of blood flow going through our aorta. That's a massive vessel. But if we have vasoconstriction of the arterioles, which are much smaller vessels that lead to the distal extremities, you can get this kind of picture right here where we have well-perfused hands with cold distal ischemic extremities. Now, we have to also consider that some pretty bad complications can occur and that prolonged constriction can lead to necrosis, right? So we talked about how ischemia is occurring. If we have less blood flow, we can have an obstruction, we can have significant vasoconstriction. But what happens over time? Things that are ischemic for a long period of time can become necrotic in the end, which is a very serious complication. Now, question writers also like you to know the basic idea that this is a triphasic presentation and that there's an ischemic phase,
a hypoxic phase, and then a hyperemic phase. And in general, the ischemic phase is going to be these white fingers that we see over here. So we have an exposure to the trigger. This causes the vasoconstriction or the ischemia to the digits. Then we're going to get the hypoxic phase. And this is where you start to see deoxygenation of the blood that's remaining in the area. So it starts to turn a little bit blue, indicating hypoxia is going on. And finally, we have the hyperemic phase. This is the red phase. This is where we have restoration of the blood flow to the extremity. An interesting clinical feature they also like you to know is this particular finding, which is livedo reticularis. So we've talked about this in some other videos. This is that lacy, purplish rash that can occur on the extremities, and it's a pretty unique finding. We can also see it here in Raynaud's phenomenon. Now, when we move on to our diagnostics here, there's not a whole lot that I need you to know because this is mostly a clinical diagnosis, right? If you see this image, you see these extremities and they're very cold and they rewarm over time, this is indicative of Raynaud's phenomenon because again, we said this usually lasts for about 10 to 20 minutes. Now, we can also consider the fact that we may need to work up the patient for underlying diseases. We talked about up here a variety of different things that can be associated with this condition, right? If somebody presents with Raynaud's phenomenon, well, maybe we need to work them up for a lupus if they have other presenting signs as well. But there really is no specific lab or specific imaging that you need to do. Really, this is a clinical diagnosis based on patient symptoms and presentation. Now, when we think about the management here, we really want to aim to avoid triggers. And so what does this mean? Well, things that can cause these vasospastic episodes, right? So things like cold exposure, when our hands get really cold, we have vasospasm in the extremities. Why? Because we want the blood in our core. We want to keep our body core temperature elevated at the expense of having cold extremities. As you can imagine, this can trigger an event, right? This can trigger an episode. If we have the extremities cold, we're inducing vasoconstriction of the extremities. That can obviously lead to this presentation. Now, some other key things they'd like you to know include certain medications that can trigger this. Again, these include things like beta blockers. Additionally, we also want to stop smoking for a variety of different reasons. But as it pertains to this particular condition, smoking is a known vasoconstrictor, again, prompting us to experience more of these episodes. And finally, the last one they like you to know is stress, right? Stress can cause us to be tense. It can cause our vascular system to constrict as we activate our fight or flight response. This can again lead to these episodes of Raynaud's phenomenon. Now, other than avoiding triggers, what can we do to actually treat this patient pharmacologically? Well, the first line medication here is going to be your calcium channel blockers, specifically nifedipine. And why are these useful? Because these medications counteract the vasoconstriction. They're calcium channel blockers. So they block the constriction, they block the action of calcium, which leads to overall vasodilation or allows for reperfusion of the extremities that can be suffering from this condition. So a possible vignette they can use to test this information is to include something along the lines of a 29-year-old patient who recently moved to Colorado from Nevada comes to the clinic with a chief complaint of white finger discoloration that is worse when walking outside. The fingers tend to turn bluish and return to their normal color upon returning from the walk. Vital signs are within the normal ranges, and the question then asks you, which of the following is a possible pharmacologic treatment option for this patient? Well, you can imagine that this patient has moved from somewhere very warm in Nevada to somewhere that's a little bit on the colder side in Colorado. They tend to have worsening symptoms when they're walking outside, indicating they're likely exposing themselves to a cold environment that is leading them to have the whitish finger discoloration that improves when they return home from their walk. So a possible pharmacologic mechanism that we can use here would be nifedipine, a calcium channel blocker. We want to avoid things that would make it worse, such as beta blockers. That could be a tricky one that they try to give you as well to lure you into it. And we also want to be mindful of the fact that there are a lot of non-pharmacological things they can do, like avoiding these triggers and exposures. So just a really quick summary of this video. Raynaud's phenomenon deals with reversible vasoconstriction of the arteries and arterioles. Primarily, it's idiopathic, but secondary can be caused to a variety of different conditions, which we talked about here. This is typically going to affect the distal extremities, and usually it resolves in 10 or 20 minutes once the extremity is warmed and you're able to reperfuse the system. There's 3 primary steps here, right? We have a whitish discoloration, a bluish discoloration, and then a return to normal skin color. When we think about the diagnostics here, we have to note this is typically a clinical diagnosis. But we can consider the fact that we should look at underlying diseases, particularly if patients have more than one symptom. If they just have this in isolation, maybe it's just that in isolation. But if they have multiple symptoms, right? They have some kidney troubles, they have some other rashes that they're talking about. We need to work out for some of these other conditions that could be affecting them as well. When we think about our management here, we're really going to try to avoid the triggers. And then if we need to, use pharmacological intervention with calcium channel blockers. Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about a couple conditions, and we're going to talk about scleroderma, both the limited and diffuse form, and a little bit about another condition called mixed connective tissue disease. As you'll see, there's a lot of overlap between some of these autoimmune conditions in terms of how they are going to present in patients. So when we think about sclerosis, we're thinking about a systemic autoimmune condition, right?
And this autoimmune condition causes fibrosis throughout the body. This is widespread fibrosis. So it affects not only the skin or the physical manifestations that we can actually see, but it also affects the internal organs, which, as we'll see, can be life-threatening for some of these patients. Cases present on a continuum from very mild to moderate to very severe. And we'll talk about those key differences during this video. So if we first look at the pathophysiology here, overall, it's a fairly poorly understood condition. But we know it's an autoimmune, non-inflammatory vasculopathy that leads to fibroblast activation. And remember, fibroblasts are types of cells that are used in establishing or creating connective tissue throughout the body. So if we have more of them, it makes sense that we're developing too much connective tissue. Too many fibroblasts are being activated. This leads to increased collagen synthesis and deposition, and ultimately organ fibrosis. Again, the organ can be the skin, the manifestations that we see externally, or manifestations that occur more internally. Now, if we think about the presentation here, it's going to be more common in women than men, and it's typically in kind of that 30 to 50-year-old range. And so again, I've mentioned this before, but we want to think about when we're answering test questions, who is it they're talking about? Who is presenting to the clinic or the emergency room, or who's in the operative room? Is it a 20-year-old or a 60-year-old? Is it a man or a woman? What's their descent? All these things are clues that we can use to get questions right on test day. Now, what's really high yield for this condition is to remember that you can get both cutaneous manifestations and non-cutaneous manifestations. So some of the cutaneous manifestations are going to include things like thickened skin and fibrosis. Why does this make sense? Well, because we have increased activation of the fibroblasts. We said fibroblasts make connective tissue. They stimulate more connective tissue, so we get more fibrosis, more collagen synthesis and deposition in the body. We can also see things like pruritus or itching, loss of wrinkles, and telangiectasias. We're going to talk a little bit more about some of these key manifestations in just a moment, but we want to also think about other things, the non-cutaneous manifestations that we can see, such as Raynaud's phenomenon. We have a whole video about that. And remember, that is the over-exaggeration or the vasoconstriction of the arteries and arterioles that go to our distal extremities. Those are the people that can present with white fingers or toes that can ultimately become a bluish color and then a reddish color as they establish reperfusion. Again, patients can also have a decrease in renal function, as well as oliguria, microangiopathic hemolytic anemia, pulmonary hypertension, interstitial lung disease, GERD, and constipation. And so we don't need to go through each of these individually, but let's think about how these all can relate back to increased collagen synthesis, increased fibroblast activation, right? We essentially have thickening. We have contracture of a lot of the structures in the body, and this is why we get the internal organ damage. This is why we get the pulmonary hypertension. There's too much collagen synthesis and deposition throughout the body, affecting all of the different organs. And so, for instance, with the renal function, right, increased collagen deposition can lead to thickening of the renal arteriolar walls. And what's this going to do? Well, it's going to decrease renal blood flow overall, and less blood flow getting to the kidneys can ultimately lead to long-term damage in the kidneys and some of these findings that we see here. Again, we can extract this to other things. What about GERD? Well, increased deposition of collagen can lead to esophageal dysmotility. This can then lead to dysphagia and ultimately reflux as well. So again, all of these things have in common that we have increased activation of the fibroblasts, increased collagen synthesis throughout the body, and this can lead to a variety of different problems. Now, when we think about scleroderma, we have to break it up into two key types they'd like us to know on test day. One of those is called the limited type, also referred to as CREST syndrome. CREST syndrome is an acronym for calcinosis cutis, Raynaud phenomenon, esophageal dysmotility, sclerodactyl, and telangiectasias. And obviously CREST goes along with each of these red highlighted letters to remember this constellation of findings. Exam writers also like you to know some classic physical exam findings and be able to recognize them in pictures on test day. So as you can see, we have a patient here with telangiectasias. Here's a digit of somebody who has systemic sclerosis. You can see a little bit of potential calcium deposits, as well as an area of necrosis. And here we have the physical exam finding of sclerodactyly. So let's take a closer look. So on this patient's ear, you can see a bunch of small dilated vessels. And this is what we mean when we say telangiectasias. They kind of have this spider-like or hair-like appearance, and they're a bunch of red dilated vessels. They can be present on the ear, the face, the arms, really anywhere in the body. Additionally, we could look at this finger over here of somebody who has sclerosis. We can kind of appreciate the skin tightening right here. It's not really wrinkly, potentially an area of ischemia or necrosis, and some white stuff potentially indicative of calcium deposits as well. If we look at the images of the hands, this is a pretty classic picture of sclerodactyly. You can see how tight these hands are, right? You can appreciate the skin. It's very taut. It's not loose. It's not wrinkly. This is also consistent with patients who have scleroderma. Now, it's a key point here that patients who have the limited form of scleroderma have a more benign course. They have less skin involvement and overall a slower onset. And so, of course, now we have to turn our attention to the diffuse form, which has widespread skin thickening and multi-organ involvement with life-threatening complications. So we talked about some of them, but just as a reminder, one of the big ones is going to be renal involvement. So patients can get something called a scleroderma renal crisis. And this is considered a medical emergency. This is very, very serious. And so the key here is that
patients might present with a lot of similarities, right? But in the limited form, it's a little bit more benign, a little bit more simple. When we start talking about diffuse systemic sclerosis, we're talking about life-threatening things. We're talking about multi-organ involvement. This can be the GI system. This can be the renal system. This can be the pulmonary system as well. And so at this point in the video, you're probably recognizing that we've been talking about scleroderma the whole time. But what about this other condition? What about mixed connective tissue disease, or MCTD? Well, overall, this is a lower yield subject for testing. But question writers really want you to be able to differentiate this condition versus scleroderma. So if we think about MCTD, it's important to note there are a lot of overlapping characteristics of three different syndromes: systemic sclerosis, SLE or lupus, and polymyositis. Typically, this is mostly common around the same age range, the third, fourth, maybe fifth decade of life, and a lot of the initial findings are similar to some of these other conditions, this triad of symptoms, but they can be a little bit milder. The key one that I really want you to know is about the Raynaud's phenomenon, because most patients who have MCTD or mixed connective tissue disease are going to present with this physical exam finding. And so one of the ways they might test this on test day and see which students know MCTD versus scleroderma is to give a more benign course. Additionally, we're going to talk about the diagnostics, one of the key differentiating tools that we use to differentiate scleroderma versus MCTD. So if we think about those diagnostics, a lot of our autoimmune stuff is going to deal with autoantibodies. So here we have the anti-centromere antibody, which is seen in limited sclerosis, and the anti-SCL70, which can be seen in both, in addition to the anti-RNA polymerase 3, mostly just seen in diffuse sclerosis. So again, knowing these three different things and which ones you would likely see in which type of scleroderma is useful for testing. And here it is again, our non-specific serology, the anti-nuclear antibody, the ANA, is often one they will give to students, because if you don't know that this is not pathognomonic for any particular disease, you're going to get really confused. ANA does not mean somebody has rheumatoid arthritis necessarily. It does not mean they have scleroderma necessarily. It's a lot of different things the patient can have if they have a positive ANA. Now, again, I talked about the key differentiating thing here between scleroderma and MCTD is not only in the clinical course, but also in the autoantibody. So MCTD is going to have the anti-U1-RNP antibody, and this is pretty unique. I think early on in our medical training, this is pretty much pathognomonic, and so if a question gives you the anti-U1-RNP antibody, you can be pretty confident that they are leaning you towards MCTD or mixed connective tissue disease versus a similar condition like scleroderma or lupus. Now, when we think about management here, it's really going to be about symptom management. Again, this is an autoimmune condition, so we're trying to treat the things that come up as they come up in the body, but we don't necessarily have a cure for all of the symptoms that present. So we have to think about what kind of things could a patient present with that would need to be treated or would need to be symptomatically managed. Well, we can think about a lot of the symptoms we talked about. So we talked about Raynaud's phenomenon. So calcium channel blockers can be used for that. It's a very good mechanism to allow the vasculature to relax. The vasoconstriction in the fingers and the digits is the problem. If we give a medication that allows this mechanism to be blocked, we get more blood, more perfusion to these extremities. This can help with that symptom. Patients can also benefit from PPIs, or proton pump inhibitors. And again, we talked about this previously, why patients are at a higher risk for GERD and reflux because of the deposition of collagen in the GI system. Another symptom we can have is cutaneous fibrosis, and so methotrexate has been used for helping with this symptom. In addition, we have PDE5 inhibitors or endothelin receptor antagonists for pulmonary hypertension, and angiotensin converting enzyme inhibitors for scleroderma renal crisis. Again, we talked about this can be a multi-organ or multi-system problem, so we have to treat all of these different symptoms. We have a GI finding, right? We have a skin finding, we have a lung finding, and we have a renal finding as well. So a possible vignette they could give you testing this information includes something along the lines of a 42-year-old patient with a medical history of interstitial lung disease presents to the clinic with a chief complaint of increasing acid reflux. The patient reports she feels well overall, but has previously been told she has a thyroid disorder. On physical exam, you notice several small vessels that are dilated around the left ear, and the question is asked which of the following antibodies is most closely associated with this patient's condition. Now, this could be a tricky question, right? They're likely to give you a variety of different antibodies for rheumatologic diseases. They can give you rheumatoid factor, they can give you anti-double-stranded DNA, which we associate with lupus. They're probably going to give you ANA because they like to include that in all the questions, but it's really going to come down to one of these. There's not enough information in the particular question I gave you to determine is it limited versus diffuse, so one of these is likely to be the answer. If they gave you more clinical findings, right, we're starting to talk about organ involvement, so I'm leaning towards thinking this is about diffuse. I would say that this would probably be the better answer here, right? Why? Because we talked about her interstitial lung disease. So she has pulmonary involvement. She's having increasing reflux. She's having GI involvement. So when we start to talk about significantly impacting the organs in the body, we're more likely leaning towards diffuse sclerosis. This becomes readily obvious if the question then goes on to talk about their creatinine has tripled over the last few days and they're starting to show some signs of chronic kidney disease. This again further indicates more organ involvement, more likely to be diffuse. So just a quick summary of this video. Lots of content here, two similar but distinctly different pathologies we talked about, scleroderma mostly, and MCTD or mixed connective tissue disease. These are autoimmune conditions that essentially lead to increased fibroblast activity and increased collagen synthesis and deposition into the body. This can present with both cutaneous findings and non-cutaneous findings, and we have to keep the two key forms of scleroderma in mind. There's limited and there's diffuse. When we think about MCTD, it's hard to pick this out in a question because it's a combination of three different conditions: systemic sclerosis, lupus, and polymyositis. And so the key to differentiating these is going to come down to the diagnostics. Which type of antibodies are we talking about? Are we talking about these antibodies, or are we talking about the anti-U1-RMP antibody more consistent with MCTD? When we talk about management here, we're really doing symptom management. We can treat for vascular changes, we can treat for GI changes, we can treat for skin changes, pulmonary changes, and kidney changes as well. Again, this is a multi-system, multi-organ pathology that patients can be dealing with.
Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about an extremely high yield condition known as sarcoidosis. So sarcoidosis is a multi-system disorder that can occur and affect areas throughout the body. It can present with some non-specific symptoms such as fevers, malaise, and there are also a lot of very classic physical exam findings that we're going to talk about throughout this video. A key point about sarcoidosis is that this is a condition that presents with non-caseating granulomas and that there's not necrosis in the center of the granuloma. This is a key differentiating feature from something like tuberculosis, which does have caseating granulomas. It can also present with some similar findings like a cough. We don't want to confuse these two things on test day, but we also want to be able to recognize what are the physical exam findings that the test writer is including to lead us to the answer of sarcoidosis. So we're going to start out with talking about the pathophysiology as we typically do. And in sarcoidosis, we typically have an antigen trigger that leads to increased inflammation with an immune response that ultimately forms a non-caseating granuloma in the body. And so what happens is we intake an antigen into the body, right? We get activation of our cells, and our macrophages are then going to respond to that antigen, right? It's a foreign particle that's in the body. Our immune system is going to respond. Certain cells in our body known as dendritic cells then take the foreign antigen to the lymph nodes where we can start to have this immune reaction. One of the key things that they want you to know about on test day specifically regarding the pathophysiology is the formation of the granulomas. So what happens is that macrophages activate the T1 cells, which increases interferon gamma release. In the release of more interferon gamma then leads to the formation of epithelioid cells. And an epithelioid cell is a type of macrophage that has differentiated itself so that it can be used to form the wall of a granuloma. And just as a quick reminder, if you haven't heard the term granuloma in a while, a granuloma is a collection of macrophages in the body that can come together to wall off an area. Oftentimes this is relating to chronic inflammation throughout the body. Now, it's also key to know, particularly later on when we talk about diagnostics, that these epithelioid cells can produce angiotensin converting enzymes. We have an increase in ACE, and they also produce more cytokines throughout the body. Additionally, test writers like to ask you about the calcium dysregulation. So one thing we'll see in these patients is that they have a high level of vitamin D and ultimately hypercalcemia throughout the body. It's a very classic way they will test you on this concept, is to give you all the labs and show you that, oh, this patient has a above normal calcium level, indicating they might have something going on, potentially sarcoidosis. And the way this works is that the increased activity of the macrophages increases the activity of the enzyme 1-alpha hydroxylase. And if you recall from learning about the renal system and the nephrology system, 1-alpha hydroxylase is the enzyme that converts inactive vitamin D to active vitamin D. And so this is going to lead to increased calcitriol, which is the active vitamin D, and ultimately increase our vitamin D levels, leading to hypervitaminosis. This is important to know because patients who have hypercalcemia can lead to a variety of other findings, such as constipation, psychiatric changes, kidney stones, and other things that can occur with high levels of calcium throughout the body. So if we turn our attention to the associated conditions here, we'll see a couple key ones I'd like to talk about, and that is the increased risk for malignancy. This especially includes things like lung cancer or lymphomas. Additionally, these patients are also at an increased risk for cardiovascular and pulmonary conditions. These can include things like aspergillomas, bronchiectasis, pulmonary fibrosis or hypertension, and myocarditis. And so we have to keep these in mind. These are typically more seen in advanced conditions of sarcoidosis, but we have to know that patients who have sarcoidosis, if we're not treating them, there are additional complications, additional things that can occur down the road. One particularly tricky association I've seen them asked about with sarcoidosis is the facial nerve palsy. This can occur in approximately 5% of individuals. This is part of a constellation of findings that a patient with sarcoidosis can have, and sometimes this is referred to as neurosarcoidosis. And so we have to keep this in mind because this is not really an intuitive thing that we think about with sarcoidosis. Often students are jumping to the pulmonary findings, which is very reasonable because of the first things that we think of when we talk about primarily lung-based pathology. But there are a lot of other key things that we need to know. Again, this is kind of like lupus. This is kind of like scleroderma. It's a multi-system, multi-organ involvement. We have to be able to differentiate these on test day. Now, when we think about the presentation here, this is more common in women than men, typically in that 30 to 55 age range, and the prevalence is increased among African Americans. So sometimes early in a question stem, they will talk about whether or not we're dealing with a Caucasian patient, an African American patient, and they're typically telling you this because it's useful for the question stem. This usually is not just information they're giving you for no reason. They want you to know some key associations, right? And so we want to keep these things in mind, but we have to consider the whole clinical picture, right? We can't just make associations and jump to conclusions. We have to think about the picture as a whole. We have to look at all the labs. We have to do the physical exam and gather the history so that we can give the best diagnosis for our patients. Now, when we think about some of the other clinical presentations, keep in mind this can often be asymptomatic in early courses. Patients might not know that they have this condition. However, as they start to develop symptoms, they can get systemic symptoms, cardiovascular pulmonary symptoms, and some additional manifestations as well. So some of the systemic symptoms are fairly nonspecific, like fever, fatigue, myalgias, and weight loss can be associated with a variety of different things. But some things like the cardiovascular and pulmonary conditions such as chest pain, cough, and dyspnea in combination with some of these systemic findings can help us start to build our differential diagnosis. Now, some of the other additional findings they want you to know on test day are really where we can start to say, yeah, this is likely to be sarcoidosis, because so far some of these findings are really nonspecific. These can be present in a lot of different conditions. But we think about these in constellation with things like anterior uveitis, arthritis, the butterfly rash that we can also see in lupus, things such as erythema nodosum and lupus pernio. Now that we have all of these constellations of things, we can think about, is this patient likely to have sarcoidosis? Do they have a lot of these findings? Or do they have just some of the non-specific ones like the systemic findings mentioned above? So I want to draw your attention to these images over here because we're going to talk about two key important findings that they're going to want you to know on test day. And so this first image is erythema nodosum. So you can appreciate the difference in skin color between these areas right here, these dark purple nodular areas versus the regular skin color up here. And this is due to inflammation of the subcutaneous tissue. Again, I said sarcoidosis is a multi-system disorder, and this particular finding, erythema nodosum, classically presents on the patient's shins. And right next to it, we have a very classic finding of lupus pernio. And these are purple nodular areas on the nose and cheek. Again, this is a cutaneous manifestation of sarcoidosis, which we know is a multi-system disorder. Now, while this video mostly falls under the umbrella of sarcoidosis, there's a particular pathology they'd like you to know by name, which is considered to be a subtype or variant of sarcoidosis, and that is Lofgren syndrome, which is going to include a fever plus bilateral hilar lymphadenopathy, erythema nodosum, and migratory polyarthritis. So again, these patients have very classic similar findings of sarcoidosis, but this constellation, in addition to the fever, has its own separate name. This is important because overall this has a very good prognosis for patients going forward. Now, when we think about our diagnostics here, the absolute highest yield thing in this video is the chest x-ray showing bilateral hilar lymphadenopathy. And so you can see that right here. And so this is a basic chest x-ray. You can see the outline of our mediastinal structures. Here I'm kind of going around the heart. We have our diaphragm down here. We have a bunch of different ribs. And what we have here is a bunch of white stuff. This is the hilar lymphadenopathy. That is to say, this is an area that has enlarged lymph nodes in the chest. This is a very classic finding for patients who have sarcoidosis. And if they show you this image on test day, they expect you to make that connection. When we think about our serum labs here, we're going to have elevated levels of ACE or angiotensin converting enzyme. And this goes back to what we talked about previously. Why do we have higher levels? Because we have formation of these epithelial cells, which increase the levels. We know that angiotensin converting enzyme is an enzyme we typically make in the body when it's needed, but here we have a situation where we might have an overabundance or we might have too much of it present in the body. Additionally, we can also see things like elevated ESR and CRP as this is an inflammatory condition, and elevated levels of calcium. Again, thinking back to pathophysiology here, we talked about why this might be. We have macrophages that have P1 alpha hydroxylase enzyme. This is going to lead to increased active vitamin D, ultimately leading to hypervitaminosis in the body. Additionally, they'd like you to be familiar with the biopsy results. So we're going to have a non-caseating granuloma with giant cells, which we can see on this image right here. So here's a really nice image of these non-caseating granulomas. I'm outlining them here. And as you can see, it's non-caseating and there's not necrosis in the center. We have all of these purple areas, these cells that are alive. However, there is clearly a very distinct wall around this structure. Another unique lab finding I'd like you to know is the fact that a bronchial lavage or BAL is going to have an increased CD4 to CD8 ratio in patients who have sarcoidosis. In that typically there's a 2-to-1 ratio of CD4 to CD8, but patients who have even higher levels than the 2-to-1 ratio we would expect can be indicative of an underlying pathology, potentially sarcoidosis in this condition. And finally, the last thing they'd like you to know is that PFTs are consistent with a restrictive lung disease. And recall from pulmonology, a restrictive lung disease is going to have a lower vital capacity, a lower total lung capacity, a normal to decreased FEV1, and a normal or increased FEV1 to FVC ratio. So if you're unfamiliar with those terms and that concept, I'm going to refer you over to our pulmonology section for more of a deep dive in the PFTs or the pulmonary function test. Now, when we think about the management here, we're going to keep it pretty simple for this video, but it's really just going to be glucocorticoids for systemic or extrapulmonary symptoms. And they also like you to know that isolated pulmonary sarcoidosis does not require treatment. So if somebody just has lung findings, if they don't have these additional manifestations, they don't necessarily need to be treated if it's the lungs in isolation. But as the disease progresses, they typically get more and more symptoms as time goes on. So a possible vignette they can use to test this concept is to give you something along the lines of a 31-year-old patient presents to the clinic with new onset dyspnea, malaise, and redness in her eyes. The patient also reports noticing nodular purple lesions on both of her cheeks right next to her nose. On physical exam, the patient has hepatosplenomegaly, and the chest x-ray shows the classic hilar lymphadenopathy. Based on these findings, you're going to diagnose that this patient has sarcoidosis, but the question then asks, which of the following is an associated condition with this patient's presentation? And they can give you a lot of different options here. Again, a very tricky one would be to say that this patient has a cranial nerve palsy potentially. They could have neurosarcoidosis. Other potential correct answers could be something discussing increased risk for kidney stones or nephrolithiasis. Why would they have an increased risk? Because these patients are typically hypercalcemic, particularly due to the fact that they have increased macrophages and increased activity of the 1-alpha hydroxylase. So there's a lot of different answers that could be correct here. But this is why it's important to know some of the key associations with these conditions and with these pathologies, because they like to ask about that on test day. So we went over a lot in this video, but just as a quick review, sarcoidosis is a multi-system inflammatory and immune reaction that leads to non-caseating granulomas. The increased activity of macrophages increases 1-alpha hydroxylase, leading to hypervitaminosis. There are a variety of associated clinical conditions they like you to know, but we have to really know some of the clinical findings. There are some very non-specific things like fevers, weight loss, myalgias, but we couple that with some other findings, some chest problems, some cough, we have the heart, the lungs involved. We can even get skin involvement, which we talked about here, as well as joint involvement. And so it's really these constellations of findings that leads us to the diagnosis of sarcoidosis. The key diagnostics here are really important. We have to know and recognize this x-ray right here. The bilateral hilar lymphadenopathy is super high yield. The elevated levels of ACE and elevated calcium is high yield. The non-caseating granulomas they love to ask you about, and they love to especially show you this image right here and say, does this student know the difference between a non-caseating granuloma versus a caseating granuloma? Lower yield is the bronchial lavage and the PFTs, but we mentioned them here just for completeness. Management is really simple for this video. Glucocorticoids for a patient unless they have isolated pulmonary sarcoidosis.